raised blue hand function if you wish to ask any question or make a comment. As we know, there's always a risk we run into technical problems, and if that happens, then our patience is required. Should this occur, we'll adjourn the meeting while the fault is addressed, and the public broadcast will be paused. If it isn't possible to address the fault, the meeting may well be abandoned until such time it could be reconvened. I'd like to remind everybody, please, that all virtual meetings will be recorded and that these recordings will be published on the Council's website. Members, I will begin by calling the names of all members of the committee to establish your presence. Could you please unmute your microphone and confirm your presence? The top of the list is Councillor Connor, and we know he is not here. So move on, please. Councillor Lorna Dupre.
Present.
Thank you, Lorna. Councillor Reynolds.
Present, Chairman.
Thank you. Councillor Hay. Anne, are you there?
Present.
Thank you. Councillor Harford.
Present.
Thank you. Councillor Jones.
Present.
Councillor Nessinger.
Present.
Thank you. Councillor Smith.
Present.
Thank you. Councillor Van der Ven.
Present.
Fellow District Councillor Sam Clark. Sam, you there?
Yes, I am now. Sorry about that.
That's all right, my dear. It's not your fault. It's okay. East Cambridgeshire District Councillor Ambrose Smith.
Present.
Thank you, David. South Cambridgeshire District Councillor Jeff Harvey. I'm still waiting for Jeff. Okay, we'll move on. Cambridge City Councillor, Councillor Massey.
Present.
Thank you. Welcome, Nikki. Huntingdonshire District Councillor Taverner.
I had an email from Councillor Taverner 5 minutes ago saying that she's had to attend a dementia meeting for a relative. So,
oh dear,
she's giving her apologies.
And there's myself, Councillor Hudson. Okay, we move on to apologies and declarations of interest, please. Rob, can you update us on any apologies that we know of?
The only apology I think will be Councillor Taverner and possibly Councillor Connor.
Yeah, okay, thank you. Does any member wish to declare any disclosable peculiar interest or non-statutory disclosable interests, please? Thank you.
I think Councillor Harvey's joined us.
Hello, Jeff. Welcome.
Hi. Sorry, I'm late. I had a bit of trouble.
Yeah. You're not on your own, my friend. It's okay. We're on item 2 now. We're asked to approve the minutes of the meeting, which was held on the 17th of September, as a correct record. Can I please ask any member who does not agree with this proposal to use the raised hand function now? And there's no raised hands, so I'll take it that we all agreeable and we go with the recommendation to approve the minutes, and I will sign a hard copy when and if ever it's safe to do so. Thank you. Item 3 is the minutes action log. This is for noting, and it was circulated on email on the 30th of October. Can I please ask the officers if there are any further updates to what has already been included on the version we have all received?
No updates that I'm aware of.
Okay.
None that I'm aware of.
Thank you. Councillor Van der Ven, you have your hand up, Susan.
Thank you, Chair. Yes, on the final, sorry, the number 3, the tackling obesity item. I think we need to be a little bit more focused on the purpose of this piece of work, which relates directly to the public health grant for well, it comes out of that of the public health grant, and so if that could be noted, and I think some indication of a conclusion to this work, needs to be framed a little bit more tightly, rather than an open-ended thing.
Yeah, there's more work to be done. They ran out of time, unfortunately.
Yeah, no, I just Sorry, Chair.
So we're hoping for some sort of a paper next meeting.
Yes, yes.
I'm sure our vice chair will sort that all out.
Yeah, I simply meant that recording this in the action log.
Yeah, of course.
Thank you.
Yeah, absolutely. Thank you. Lorna?
Yes, the action on the meeting of 25th June, the first action, arranging meetings between members of the committee and the CCG. It's quite clear, as we discussed last time, from the subsequent cells in that row, that it's meetings with CCS. And I wondered whether CCG in the first cell actually ought to be corrected to avoid further confusion.
Yes. I think that's right, Liz. Yeah, absolutely. Thanks, Lorna. We'll do that.
Well, but yeah.
Exactly. Is there any other questions at all? The action log. Okay, thank you. We go on, please, to excuse me, item number 4, which is petitions and public questions. We have received no public questions, but we have received one petition for our consideration. Before I ask the petition spokesperson to present the petition, could I ask Democratic Services, please, to read out the details? Rob, it's you.
Thank you, Chairman. The petition has been received with over 1,400 signatures from addresses within the Cambridgeshire County Council area titled "Reverse the Outsourcing at North West Anglia Hospitals," with the text of the petition reading: "A few weeks ago, NHS staff were praised as heroes, but now North West Anglia Foundation Trust, NWAFT for short, want to sell us off to a new private employer. In cleaning, catering, linen, patient services, porters, post room and security, we've been giving our all during the pandemic and long before, but as thanks, we face being thrown out of the NHS family. Indeed, the trust which runs Hinchingbrook, Peterborough City and Stamford and Rutland hospitals chose to tell us we would be sold off in the middle of the pandemic. The trust wants to outsource more than 70 of us, joining over 100 workers currently employed by 3 different private firms into one single contract. Outsourcing is bad for staff. Workers are paid less than their directly employed NHS colleagues. Conditions are worse, standards are worse, and morale will plummet. And it's bad for patients as well. Private providers are responsible to their shareholders, not the public. Outsourcers are driven by getting a profit out of the contract, not providing patients with the best possible care and support. There is plenty of academic research to show that hospitals with outsourced cleaning departments have lower standards of cleanliness than in-house services. This is particularly concerning given the ongoing threat from coronavirus and the real possibility of future spikes. We're calling on the Trust to stop this outsourcing immediately and keep us in the NHS. Supported by our unions, Unison and Unite, we are calling on the Trust to reverse the existing privatisation of services across the 3 hospitals and bring everyone back in under a single employer, the NHS. That concludes the petition wording.
Thank you. Can I please confirm if the petition speaker has joined us?
I have.
Thank you. Nice to see you. So, members, I welcome Cheryl Godber, who will be speaking to the petition. Our constitution allows you, Cheryl, up to 3 minutes to present the main issues. After you have spoken, I will ask if any members of the committee have any questions of clarification they wish to ask. To help you keep track of time, a member of the Democratic Services Department will inform you when you have half a minute left if you have not finished after 2.5 minutes. Cheryl, I would like you now to please give us more details.
Okay, thank you, councillors, for having me to your meeting today to present this petition. I'm a Unison regional organiser and I represent members over at North West Anglia Foundation Trust, many of which are impacted by the North West Anglia's decision to continue outsourcing and further outsource. So just to give you a bit more background in terms of where things are at. As has already been mentioned, North West Anglia already has a number of its soft FM services delivered by a variety of different private contractors. These contracts are due to come to an end in January 2021, so next year. The Trust has made an unrecorded decision to continue outsourcing services, and not only that, to add more in-house service, currently run in-house services to that contract to be delivered by one private contractor with a contract value of around £40 million. The 70-odd directly employed staff that the Trust wishes to now outsource are predominantly based at Hinchinbrook Hospital and deliver services such as logistics, post-room services, cleaning, patient services, as well as an award-winning catering service that cooks from fresh, locally sourced produce. These staff are concerned, very concerned, not just about their own future under a for-profit private contractor, but also for the future of the quality of services, particularly in the middle of an ongoing pandemic. They believe, as we do, that it would be best to bring everything back in-house under the Trust's direct control. They believe, as we do, that's better for services, better for patients and their families, better for staff and the NHS team as a whole. Not only do the staff have these concerns, but as has been reported to you, so do over 1,400 people that Cambridgeshire County Council represents, who have also signed this petition. And just to add a couple of additional points, the Trust has not provided any rationale for their decision to continue and further outsource key services. The Trust has not provided any business case to support their decision, nor any community impact assessment on that decision. The Trust has no formal record of this decision being reached, despite the value of the contract being around £40 million of public monies. The Trust has only now started to look at what services would cost if delivered in-house, and yet refuse to halt the outsourcing process. So, councillors, I present this petition to you on behalf of Cambridgeshire residents and ask this committee to take any action in its power to hold North West Anglia Trust to account and to allow for proper public scrutiny of this decision, which we believe will impact on Cambridgeshire residents, service users and their families. Thank you for listening to me today.
Thank you, Cheryl, and that's very good, thank you. Members, as there is no report on the agenda, the Council Constitution on petitions does not allow debate on the issues raised, and the normal procedure would be that the Service Committee replies within 10 working days. However, we can ask questions, but these can only be questions of clarification. So if any member has any questions of only clarification, please raise your blue hand. And once we've had these questions, then I'll go on to a possible option to move forward. And the question is from Councillor Jones. Linda, please.
Thank you. I had three clarifications, if I may be indulged to have them. The first was, I didn't understand what you meant by an in-house bid. I think you said something about there wasn't an in-house bid, so could you clarify that? The second issue was you talked about the hospital catering being award-winning, and it would be helpful to have that clarified. And the third issue was just to be clear about what you're asking the committee to do. Thank you.
Thank you. Cheryl, do you want to answer those questions? Cheryl, are you there?
Sorry, Chair, she's just coming back now.
Cheryl, can you hear me? Hello, there you are.
Sorry about that. I keep for some reason dropping out.
Okay. Would you like Councillor Jones to repeat her questions?
No, I think I got the gist of the questions, Councillor Hudson. In terms of an in-house bid, What should happen is where an organisation is looking to outsource or continue outsourcing its services to a private contractor, where there's a possibility or a push for those services to be delivered in-house, then there should be an option for that to be looked at properly as an alternative option to privatisation. The trust has only just recently decided to have a look at that and see how much the services would cost if delivered in-house. So they're in the process of commissioning another organisation to have a look at that on their behalf. So I hope, Councillor Jones, that answers that part of the question. In terms of hospital catering being an award-winning team, the particular team at Hinchinbrook do produce good quality food in-house, and that is locally sourced. They produce that food at a 46% lesser cost than a private contractor can produce. And for the quality of the food that they deliver, and the team that's well led, etc., they have won awards for that. I think hopefully the link to our report written by John Lister on behalf of staff and members has been circulated to you. It's from outstanding to average. I believe the Democratic Services person did have a link to that, but that would go into more detail about which awards that team has actually won. And in terms of what we would be looking for yourselves to do is to look to write to the Trust Chief Exec, actually asking yourselves for its rationale and a full disclosure of the business case for the decision it's made to not only continue outsourcing, but also to add in those additional services. To ask for the community impact assessment on their decision, to allow yourselves to have proper scrutiny, as is your right to do on this decision, which will inevitably impact on Cambridgeshire County residents, service users, etc.
Thank you. Yeah, Linda, are you happy with that? Yeah.
Yes, thank you.
Yeah, thank you. Councillor Harford, Linda.
Thank you very much. Thank you for your presentation of your petition. I wonder if you know what the currently proposed timescale is for the decision to be made on this.
Yes, Councillor Harford, and they're in the process of invitations to tender. There are 3 contractors that have expressed an interest in this one contract. They are, as of not next week, but the week after, those contractors are being invited to do presentations, and it's with a view to award the contract in January, end of December, January time.
That's very helpful. Thank you very much.
Thank you. Councillor Van der Ven, please. Susan.
Thank you. I thank you very much for the presentation. I have a housekeeping question, I guess, for the committee, and apologies if I missed anything on email prior to our meeting. I didn't see any papers on the public agenda, nothing added to our late additional papers. So I wonder if there is any written material relating to the petition that has been circulated that I may have missed, and it would be helpful to see that even if it comes a little bit late.
Susan, yeah, there is no papers on the agenda because this wasn't on the agenda. I allowed it I used my discretion to allow it as it wasn't on the agenda.
I
Hence,
see.
we can only ask questions.
I see.
I'll just
Okay.
check. It's okay. I'll just check with Rob. Rob, is there any other documentation we could have or not?
I'll certainly look back at the email that I received, but I wasn't. If there is a link there, I can obviously provide it to the committee after the meeting. But it wouldn't obviously be relevant until you've sort of for further discussion.
Yeah. If you could just check, please, that'd be great. Thank you. There are no more blue hands. Excuse me. As I said earlier, there's no report on the agenda, so we can't debate. We can only raise questions, and we have done. The normal procedure for service committees is when it's with the powers and duties of the council for officers to provide a written answer to the petition organiser no later than 10 working days following the meeting. However, one of the requests from Cheryl and her team is for us to write to the chief executive. I have another option, and that is we'll ask the chief executive directly, and we can do that because we have a team of members of this committee who are due to go to what we call a quarterly liaison at Hinchinbrook later this month, where the chief executive will be involved. And I would like to suggest that the members of that team take this petition in question and put it direct to the chief executive, please. Get the trust side, and we can compare, and then perhaps you'll report back after your quarterly liaison. Would everybody be happy with that? I think that's a real good solution because we could talk to the chief executive direct. Councillor Jones,
Thank you, Peter. That's a very imaginative suggestion. The only concern I have, given what Cheryl said earlier in answer to Councillor Harford, is the time frame. If they've got people coming in from the private sector to present, then they seem to me to have swung into a process which, unless there's, I would have thought, intervention, they're not going to abandon. So I do have a concern about that. The other issue is that although the liaison meetings are extraordinarily valuable, they are essentially informal goodwill meetings, if you like. I sort of worry about the status of raising that at that kind of meeting. We've just had a meeting with Adam Brooks this morning, for example, and there are issues around how that's handled. So I sort of have a concern. I welcome Councillor Harford's comment on that.
Yeah, well, Councillor Harford, do you want to come back on that? Because
I in my naivety, I had thought that because the contract isn't due to be awarded until January, that would give us the time to be able to raise this with the CEO at our next liaison meeting. I understand what Councillor Jones has just said about what the meetings are intended for, but quite honestly, I think that it doesn't preclude us being able to ask about this and ask what the process was, and then report back at least to the chairman and the vice chairman. I think is going to attend the next MWAFT meeting. So I don't know. I'm reading something that Kate Parker had written for us on her item on liaison meetings. I noticed the word scrutiny. So I think this possibly does fit perfectly well within it, but obviously, we need to observe the usual courtesies about how we raise it.
Yeah, I quite agree with what Councillor Jones and Councillor Harford, our two leaders, have said. However, it is a less formal meeting, so that lends itself to have a more in-depth discussion, and then we can decide where we go forward from there. I think that is a good way forward at the minute. Councillor van der Ven, Susan.
Sorry. Very quickly, I simply wanted to ask, couldn't the text of the petition be circulated to us, even if it comes late? Surely the text of the petition exists somewhere There's no point of reference at all, and the number of signatures on it would be helpful in future.
I can provide that.
Yeah.
Thanks.
Okay. I've just if I may, Chairman, I've just checked what I received, and there were no links that I received.
Okay, Rob, thanks. Yeah, of course, Susan. Rob will send all out to all members of the committee, and I think we all agree that a good way forward is to go for the meeting with the chief exec in, I think it's in a week and a half, or we'll be there. And I know that the vice chair, Councillor Hay, and I know Councillor Harford will be going. So we'll be well represented, and we'll get a good in-depth report coming back. Thank you. Cheryl, thank you for your time, and thank you for bringing your petition.
Thank you, everybody. Thank you for listening.
Thank you. Thank you, members. Interesting. So let's now go forward to, I think, item 5, which is a scrutiny item. NHS England and NHS improvement, East of England response to COVID, excuse me, and the delivery of NHS dental services in Cambridgeshire. Can I first of all welcome Tom Norfolk and Jessica Bendon from NHS England and NHS Improvement to our meeting, who will be presenting the report. We know how busy you are, you two people, and so this is a limited in time to maximum 40 minutes, and we're running over time now. So committee, bear in mind that, please, and Tom and Jessica have to leave no later than 2:35. So could I ask you to provide a short introduction to your report, please?
Yes, of course. Thank you very much, councillors, for allowing us to come today to present to you. So to give a very short synopsis, following the Prime Minister's announcement on the 25th of March in relation to implementing social distancing measures to slow down the spread of COVID, all non-urgent face-to-face dental activity was stopped. Across every NHS region, urgent dental care centres were set up and were created to provide care for those with that really had urgent dental care problems. In Cambridgeshire, there were 7 urgent dental cares put in place, and these are still currently in place to support our dental services across Cambridgeshire at the time of the restrictions. And then additionally, 3 minor oral surgery urgent care centres were set up, and the capacity of each is regularly reviewed to ensure that patients are seen as quickly as possible. The Office of the Chief Dental Officer announced from the 8th of June that dental provision could be resumed, and services are gradually being restored. However, this is based on clinical need. Nationally, between the 8th of June and the 30th of September, and this is still ongoing to this date, practices have been allowed to contractually provide a minimum of 20% of their normal contract activity. This delivery is based on fallow time, which is the need to allow the aerosol particles to settle when we do an aerosol generating procedure, to settle for up to an hour in the surgery before cleaning the surfaces and being able to see the next patient. In practice, this has reduced the throughput of patients from 25 to 35 patients per day per dentist to 5 to 7 patients per day per dentist. As they are following the guidance of the Chief Dental Officer, which is to prioritise urgent dental cases and those with outstanding treatments, very few dental practices have the capacity at the moment to see routine examinations. As I've mentioned, this is due to the restrictions of COVID and the difficulty it presents, especially around the fallow time. There are, to let you know, there are 38 NHS dental surgeries providing face-to-face services, which include aerosol generating procedures, and 7 that are currently offering advice, analgesics and antibiotics, which is 3As, which is triage over the telephone or more remote. And this is alongside the 7 urgent dental care centres that are in place that I mentioned. We have asked to support with the resumption of dentistry that all practices treat both regular and non-regular attendees that require urgent dental care, and also to provide at least one urgent dental appointment slot per day per dentist. And this is also to enable support from the 111 referrals that we receive. In addition to this, there are also 3 practices in Ely, Littleport and March that are part of the urgent care and stabilisation project, which was set up prior to COVID. And this aims to treat urgent care patients and, where appropriate, provide stabilisation to patients to improve their oral health. So, as mentioned, in order to support with the resumption of dentistry, we are emphasising the need to prioritise treatment and the urgency of need. All dental practices are being requested to have at least 1 urgent dental care slot. And we're also providing support to providers around fit testing so that they are able to wear the appropriate PPE, FFP3 masks when they are undertaking aerosol generating procedures. We have started a piece of work which is amending the directory of services. So the urgent dental care centres within Cambridgeshire will be added to the list as emergency providers, and this should be rolled out in the next week or so, which will mean when 111 receive a request for urgent dental care for a patient that may not be a regular attender, they can then be signposted directly to these UDC centres to be seen or triaged, and then if appropriate, seen for urgent dental care. Thank you very much for your time. That is the brief overview, and we're open for questions.
Thank you, Jessica. That's very good. Start with Linda, please. Linda Harford.
Thank you very much, Chairman. So I have 4 questions, please. The first one is, what percentage of the normal number of patients is currently being seen? How long are most people having to wait for an appointment? What is the cumulative backlog? And what impact do you envisage this having long term on both dental and general health? Thank you.
Yes, do you want me to have a stab at those, or do you want
that would be lovely, Tom. Yeah, I was going to ask if you could come in as the thank you.
Okay, well, thank you for the questions, Councillor. There are some difficult questions there because it's that data we don't actually keep. Practices, primary care dental practices, normal dental practices are businesses that have a contract with the NHS. So we wouldn't necessarily keep data such as what proportion of activity is going through in relation to what you're looking at. The nearest I can give you is that contracts, there's a national contract, there's a temporary contract in place which has been decided by the national team, and as Jess indicated, that's sort of started in June, the 8th of June. It has expired and we're waiting a new contract, and that has a minimum threshold of 20% activity, but it's not the activity in the old way. So the old system was based on something called units of dental activity, which is just a measure of activity. Now it's changed, and so that activity can be measured in different ways. What we do know from the latest data is that more or less we're looking at about 25% activity compared to the normal more or less 100% that was delivered. So we're down significantly on the amount of activity that's been produced. Capacity wise, and by capacity I mean the amount of time a dentist is sat in a surgery seeing NHS patients, it's somewhere around the 80% level. It depends because its variabilities are the infection rate, how well staff are, risk assessments for patients. So there's, and what we call fallow time. And a fallow time is where once the procedure's been done that generates an aerosol, that the surgery has to be left. And there's still quite a lot of debate there. So activity is down. The other questions you highlighted was what effect is this having on the provision of service? At the moment, the priority is urgent access for urgent patients, and that continues. And in actual fact, that's reasonably well. We think that access for patients with urgent problems is okay. There's obviously going to be high individual cases, but generally we've got a good UDC network, a good urgent dental care network, where patients have been seen and they've got all the PPE they need and they've been established. In fact, we established them very early on. And we've also got a lot of dental practices that are seeing urgent patients. That's not to say that every practice is, but they're all heading that way. And the long-term consequences, well, I think that you've sort of hit the nail on the head, really. I think this is something that is going to be quite difficult. COVID has highlighted a lot of the inequalities. It's made them a lot worse. We think that's where it's heading, and prevention is one of those areas. Dentistry is an area that's dental disease is self-inflicted by and large. Decay is caused by sugar. Gum disease is by and large caused by oral hygiene and issues around that, but there are other components. And of course, people have been locked down, so access to dentistry has been limited. So we're mitigating that by designing a strategy which actually sort of pulls out and transitions into a new world. Jess, do you want to talk a little bit about just sort of the strategy and where we're heading and our plans to mitigate the problems that we're feeling?
Yes, so we have drafted a transformational strategy. So Tom mentioned an old contract, which is based on the units of dental activity. So we are looking to have a more flexible contract with our providers. So it will include elements around prevention, and it will certainly be about dentists and dental practices working closer together rather than being a sole entity. So that we're hoping through this that there will be more equitable access for patients, because dental practices will come together in clusters and they will communicate about who has the expertise, if you like, to be able to accommodate that patient. And so we're hoping that will increase and support access. And also then we really do want to look at the inequalities around health. So that is around the prevention agenda and working more closely and enhancing our work with the public health services in local authorities, local clinical commissioning groups and other key stakeholders to make sure there's much more of a holistic approach to dentistry. That process is going through at the moment, and obviously it will take time to embed, but certainly models have been started across the regions that Tom is heavily involved in to model this, to see how the best way to make it work for our patients, with them at the centre of what we're doing.
Thank you. Linda, do you want to come back very briefly, please?
Oh, I've just looked at the list of speakers. I'm not going to take... But I believe that there'll be some other robust questions coming.
That's good. That's what we like.
Councillor Nessinger, please. Lucy.
Thank you. So I'm going to focus on one particular issue, which is that I think you've said that there are no routine checks going on. And I think that that's really quite a serious concern. And I'm particularly concerned about the impact that's going to have on children's teeth. I think that all children are entitled to NHS dentistry, and I would imagine that quite a large number of the normal checks that are done and that are therefore not being done are checks on children's teeth. And if none of those checks are being done at all, it seems to me that that's a really serious problem. If you think I'm wrong and that we don't need to do those checks, I'll be very interested to hear that. But presumably we do check children's teeth fairly regularly because it's felt to be important for their healthy development and the healthy development of their teeth, and so that they don't end up with worse problems than that they would otherwise have. And I think if those checks are not happening at all, that's a really serious issue, and I'd be very interested to know what you're doing to tackle that. I listened carefully to what you talked about in terms of the transformational activity and the new contract. I can see how practices working together might make more capacity for urgent care, but it didn't sound as if you were making very significant steps in terms of increasing capacity for routine care. And it does sound to me as if there is a real need for that to be made a higher priority. And it from what you've said, it sounds as if the issue is to do with physical space. And if that is the issue, what are you doing about trying to find other physical spaces where dentists can do those types of routine checks? And just so I've just about finished. My final question is every dentist activity, every dental process, including routine checks, are they all aerosol generating? Because if not, presumably then that means that there is there would be capacity to have some places set aside for non-aerosol generating processes, procedures, which could then be running at higher capacity. I hope that makes sense.
Lucy, thank you. Just before you come back on that, I just want to give a quick example that a particular thing that Lucy just mentioned. I'm sat here in Leafy Long Stanton. We have our own dental practice, and they have now started normal routine dental checks. My wife went 2 days ago. My dental practice is in Histon, and they're not starting adults until at least January or February next year, your normal 6 monthly checks. However, they have started now going through all the children on their list. So therefore, I can't get in until next year, but my wife went in 2 days ago. Okay, would you like to come back on that, Tom or Jessica, please?
Yeah, shall I have a little stab, or do you want to go first, Jess?
No, you go for it. That's absolutely fine,
Okay.
Tom.
Yeah, so I mean, 2 good points there. I think sort of Peter started to answer the question for me in that each practice is different. So to give a little bit more meat on the bones, the practices have to, as an individual practice, they need to prioritize urgent patients, so those people who are in pain. But once they've done that, based on their own risk assessment, so their team, for example, if they've got members who are particularly at risk and how they can work the safe flow of patients through their practice. Some practices are progressing a lot quicker than others, and some practices will have more urgent patients or patients with urgent needs than others. And so they will be able to transition through to seeing normal checkups, should we say, prioritizing those who are most at risk, say of disease or vulnerable children, vulnerable adults, all those sort of groups. So the question that was originally raised about are children being seen? Well, yes, they are to varying degrees. We don't know exactly how many children because it depends on the capacity of the individual practice, and that varies depending on how many patients are presenting with urgent problems to them. And so some practices are sort of getting back to normal routine checkups, as we're hearing as well. So it does sort of vary, but and capacity varies within the system. But children are being seen. In my practice, which is in Cambridgeshire, we're doing a lot of urgent patients. We've seen large numbers of urgent patients on a regular basis, but also we're looking through and screening those children who are particularly at risk of dental disease or got particular problems. We're looking, do we need to bring them in? But also, we're looking at different ways of engaging with children. We've got to move away from the idea that the only care that's provided is via a dentist and a patient presenting to them for a 6 monthly checkup. We need to vary checkups, and we need to use the wider dental team, just like GPs do. 20 years ago, it seems to me that doctors were large number of doctors, a small number of nurses, and a few receptionists. Now there's the doctors with the phlebotomists, with the nurse prescribers, with the care assistants, with the paramedics, with the prescribing pharmacists, the whole team. And in dentistry, part of the plan that Jess highlighted is to move towards a more modern way of providing dentistry. Jess, do you want to sort of add some more on that and flourish with a bit of things?
Yeah, so just to answer Councillor's question around the dental strategy and working more closely together. I do apologise if I didn't make that clear enough, that it would cover all dentistry. So it would be around routine dentistry care as well. So it would be about the capacity between them all, and very much emphasising on the preventative agenda, as Tom alluded to, with all the different staff within the dentist practice. Another point that you were asking about aerosol generating procedures. No, not all procedures are not aerosol generating. And so those that require the fallow time. And this is where Tom, as a clinician, would be able to explain that better about those that need urgent. So as he was saying, as those urgent patients may be now reducing, then more routine care comes in, and they are the ones that don't require the aerosol generating procedures. So therefore there should be more availability.
Thank you. Can I just come back very quickly, Peter?
Yeah, of course, yeah.
I'm glad to know that some routine checks are being done, because that sounds slightly different from what you originally said, and that's extremely good news. And I'm also very pleased to hear that Tom's practice is prioritising particular children, because I think that's really important. But it does sound to me as if there is an issue about just the sheer quantity, the capacity of the system. Are you looking at sending people out to, I mean, one option is to actually go and do checks of children's teeth in places other than dental surgeries. Is that being considered at all?
Yeah, it's interesting you mentioned that. It's I've been around long enough to see it come round a few times, and it's at the school dentist, and that's school dentist, as in checking children's teeth, exists for epidemiological purposes, for data collection. The difficulty is consent, and those services need positive consent from the parent, and that's not easy to get, because a lot of the children who may be from sort of more difficult backgrounds, you can't get that consent. Some parents refuse to allow it anyway. So the data that's collected is skewed anyway. So we're working from skewed data, but also how you do it is very, very difficult. And so that then leads me on, and I could talk for a long time about this. So I'll be very, very brief, just to highlight the headlines, which is the way that we provide dentistry and the dental team must change towards prevention, and we must use the dental team more widely. For example, things that we're thinking about and proposing and working up at the moment is how we use this Zoom virtual technology to provide prevention to large groups of people, to look at schools and prevention, because we can provide prevention as part of health within the school curriculum. So that can be provided. So we can do that without needing the positive consent of parents to do that sort of thing. And the same with the other end of the scale of, sort of people, old folks, nursing homes, that sort of thing, they've had a particularly tough time in the COVID environment. And we know that they've been highlighted by the Care Quality Commission with regards to oral hygiene provision and a variety of things there. Prior to COVID, we had a plan in place, and that plan is continuing, and we hope to move that out again with a preventative model that looks at what we can do for patients outside a dental practice.
I slightly suspect that you'd get a different response from parents at the moment when it's so difficult to get routine appointments, but I've had my question time. So thank you very much.
Sure, thank you.
Thank you, Lucy. Thank you. I remember the look of horror when you went to the school playground and saw the dentist caravan parked up all those years ago.
Just
Nikki.
to start going in, Peter.
Yeah, no.
Nikki, please. I was going to mention the school dentist, because I'm old enough to remember the school dentist too coming round. And again, the look of horror, go, oh my God, did I brush my teeth this morning? When you're about 7 or 8, So I won't speak about the school dentist because we've already spoken about it, but I do think it is worth looking at if there's something similar, because I think the education is great, but I mean, there is an awful lot of education on oral hygiene out there already. And so I think it's about the children who are missing bits. As you know, you're a dentist, and you can only tell that when you physically look at them. So from what I'm listening, from what I'm hearing, one of the issues is the fallow time that is needed after an aerosol generating procedure. Is that still 3 hours, or has things moved on? Where are we investigating if there's a better way to get that fallow time down?
Do you want me to pick that one up, Jess?
Yes, please, Tom.
Yeah, so the fallow time, for those people who are unsure, the fallow time is the time after an aerosol generating procedure that we allow the aerosol, the water particles, to settle onto the floor before we clean the surface. Aerosols are particularly problematic in dentistry for 2 reasons. A, because essentially the COVID virus loves the size of the water droplet that we create when we scale teeth with a machine, or when we use the drill, the Wizzy drill, the air generating drill with the water. And so it goes into the air, and then you breathe it straight into your lungs. So coronavirus goes straight into your airway. And in particular with the dental team, as a dentist and nurse, we're about, certainly as a dentist, I'm about a foot from the patient's mouth. So it's about as close as you get to it. The fallow time was originally decided. If you'd asked me what fallow was 6 months ago, I wouldn't have known. Fallow time was originally decided it would be 60 minutes, 1 hour. And that was an arbitrary figure that was decided because by that stage they thought if you vacate the room, then you can allow the aerosol to settle before you clean it away with antiseptics. There's new guidance that's come out from a group of Scottish experts, which is actually quite good. SDCEP, they produce good guidance, and that suggests going down to more or less half an hour. In fact, you could get it down to 30 minutes to 15 minutes with air exchange systems. So air exchange systems can either be something simple like the extractor fan in your bathroom, to more fancy systems that somewhere like McDonald's might have, and how many air changes you can get in a room per hour. And then if you get to a certain level, theoretically, the risk drops. But it all depends on which way you're pulling the air, because you have to pull the air past the patient and past the clinician rather than the clinician on, because as a clinician, we're high risk to patients. We present a threat to patients because of our potential COVID nature, as well as patients presenting a threat to us and patients presenting a threat to each other. So we have to be mindful about air changes. So at the moment, the national guidance hasn't changed. They haven't assimilated this new Scottish guidance, and we're stuck with the 1 hour. But various organisations are now tending towards the half an hour, the 25 minutes, 20 minutes fallow time. But it also depends on the treatment you're doing, and various things you can do in the mouth to mitigate that. So it's become a sort of real subject.
Tom, can I just stop there, please? We're quickly running out of time. There's 2 more questions left. I think that's been answered pretty well. Thank you. Lorna, please.
Thank you. I won't ask my questions about inequalities and the sort of the build-up of issues for the future, because those have been addressed, but I hope we will come back to them at a future meeting because they're very important. My questions are, firstly, I'm still struggling to get my head around the details of the new 3-tier system for lockdowns and so on. Are there any dental impacts on that? Does dentistry provision change between a level 1 and a level 3? And do you think there are likely to be restrictions on dentistry provision at level 3 in the future, if not now? My second question is at 210, I got a bit lost in this report, which was talking about the urgent care and stabilisation project and the 3 practices in Ely, Littleport and March, because we'd had paragraphs about 38 dental surgeries, 7 surgeries doing the 3As, the 7 urgent dental care centres, 3 oral surgery urgent dental care centres, and I got a bit lost as to all these different facilities and which was which, and I wondered whether you could explain what the urgent care and stabilisation project is, because it's not explained anywhere else in the report. And I think that's probably about it for now. Thank you.
Jess, do you want to go first with the urgent stabilisation, and I'll pick up the tier 1, 2, 3 and the effect on dentistry?
Of course, yes. So apologies if it wasn't clear in the report. So this was set up as a pilot pre-COVID, and at the moment in Cambridgeshire and Peterborough we have dental access centres, and these are for any non-regular patient who are in urgent dental pain. So they so this is pre-COVID, so they could attend, they could call in the morning and have an urgent appointment made, and they would be supported out of pain. But that wouldn't then mean that they would necessarily, they wouldn't be able to remain with that dental practice because it was there for urgent dental pain. So the point of this stabilisation programme was set up so that they were an additional support to the dental access centre, and then if the patient required ongoing treatment, they would then remain with that practice to be able to be stabilised back into oral health. So these practices, I believe, are all back and running now. Obviously they are prioritising urgent dental care, as we've mentioned, but that's what they were set up to do pre-COVID. And once routine care normalised routine care comes back, they would be back providing that care as they are. Has that answered the question, Councillor?
Thank you very much. Yes.
Thank you. Thank you. And the last question, as brief as you can, Linda, please. Linda,
Sorry, my other
Councillor
question
Jones.
was about the tiers, the 3 tiers. I asked.
Yes. Is there any implications to the dental work if we get to the top tier?
The very quick answer, Councillor, is very little, because we have the PPE and we have the setup. So there may be minor as we get towards level 3, but we're envisaging continuing services more or less as normal, and certainly the urgents will remain.
Thank you.
Thank you. That's so good. Councillor Jones, please.
Thank you. And I will be brief because I know we're running out of time.
Thank you, Linda.
A conversation with Tom at some point about the notion of dental work being or the need for it being self-inflicted, because I do think that it doesn't take account of the wider determinants of health and the access to things like a decent toothbrush and, you know, all the rest of it. Anyway, that's another issue. What I wanted to focus on was the future, because there's been a lot of important and robust questions about the past. And I think what you're saying to us is that you expect to be able to drive through a flexible contract which has a lot more about prevention, a lot more about dentists working in clusters, a lot more about cooperation. And I'm trying to understand how the contract can actually deliver that, because we are exactly talking about a whole collection of businesses, some of which are in probably good order and making reasonable money, and others which aren't. So I want to understand a bit more, and it may not be in the meeting, you may be able to send it to us, what this transformation strategy through the contract, through this flexible contract, is actually going to be able to achieve.
Thank you. Tom, if you'll be concise as you can, please.
Sure. So just to go back a little bit, there's been pilots looking at this. So pilots have been running for nearly a decade now, and with the national team, and there's been a reluctance to move away from the old system. But during COVID, we've lost a lot's changed. So what we're going to do is build on the learning from those pilots, we call them prototypes, and that will deliver a financial model to practices that remunerates them for prevention, access, and these other things, rather than counting a generic unit called units of dental activity. That's essentially the plan in a few sentences, but there's a whole thesis behind it. Is that concise enough, Councillor?
Yes, thank you. And when you have the strategy, is it possible to send it to us so we can, you know, the committee can have a look at it, because it sounds very interesting.
Yes, we're waiting for final sign off. Once we've got everything ready, we'll be socialising it with everybody. We're already linking with Health Watch, and so we'll be socialising it widely, and there's certainly no reason why we can't socialise it with you as well. I'm happy to come back and discuss it further.
Thank you.
Thank you, everybody. Thank you, Tom, and Jessica. It's been really good. Thank you very much for coming, and have a lovely afternoon doing what you're going to do. Thank you.
Thank you very much for having us.
Thank you.
Thank you.
Bye-bye.
Bye-bye.
Members, due to our ever hard-working Director of Public Health having to leave the committee early, I'd like to go now, please, to I think it's item number 10 in your agenda pack. Yes, the COVID-19 response. There we go. You've all had the report, Liz.
Thank you, Councillor Hudson. So you have all had the report, and I'm aware that it did come in with only a short space of time, but relatively short before the meeting. But that does mean that we can give you the most up-to-date or more up-to-date information in the report in what we know is quite a rapidly changing picture. So I'm not going to go through in too much detail today. Just a few key points. Nationally, we have been seeing a significant rise in COVID-19 cases, and clearly in Cambridgeshire and Peterborough, we have also been seeing a rise, particularly since the end of September. The latter part of September, we have seen a clear rise in cases, which you can identify from the tables and charts on page 2. So There is, and I think this was actually highlighted on Look East yesterday, that there is an issue that some of those cases may be students at external universities who haven't yet changed their GP, and so they may be coded into Cambridgeshire, even though they actually are a part of an outbreak in, say, Manchester or Newcastle. So that does have some impact on the figures, as I've noted in the paper. But even if you take those out, we are still rising, and cases in Cambridgeshire and Peterborough approximately doubled between the week ending 27th of September and the week ending 4th of October. And we're continuing to watch that closely. So a rise in cases, some rise in hospitalizations, but not a large rise at the moment. And we're seeing a greater part of our rise in the younger age groups who are less likely to become severely ill and be hospitalized. Lots going on in terms of response. I've highlighted our work with the universities and a lot of good work going on there to prevent outbreaks, which clearly is a key priority. A lot going on with education colleagues, working with schools, and also a lot of work going on around events and also the implementation of the contain framework, so making sure we have joined up systems across district councils and the county council for that, together with planning for winter and our ongoing campaigns. So I'll finish there and very happy to take questions.
Thank you. I think I'm going to start with Lorna, because you very kindly sent your questions in earlier. It was very much appreciated. Thank you.
Lorna, you're on mute.
Sorry. Yeah, just skim through my question. The period between now and the beginning of December sees a number of annual community events, all of which will be affected in some way by COVID-19 and whatever restrictions there are in place. And residents are seeking advice and information from their councillors on what they can and cannot do, and on safe alternatives to enable as much normality and celebration as possible in this very bleak time. The first of those is Halloween, which is now imminent, and I asked on the 23rd of September whether public health, comms and the police could provide advice and positive suggestions for communities on what they can do to enable some form of safe Halloween activity to replace trick-or-treating. Bonfire Night is another one, and I asked a question at full council about that, but I would be grateful for a brief response on what the public health team is doing and how they're working with others to ensure that the probable increase in domestic bonfires and fireworks doesn't result in damage to people and property. And the third one, of course, is Remembrance, which is often led by faith organisations and service organisations and civic groups, but what advice has been given to them, and how is that being shared with us? Thank you.
Thank you, Councillor Dupre, and I can certainly update you on that. So Public Health has been working with our communications team on a campaign around events, and including those events which you have talked about: Halloween, Bonfire Night and Remembrance Sunday. So we always have to make sure we don't confuse people. So we do try to make sure that our guidance is aligned with the government guidance, which we are expecting imminently around Halloween and Bonfire Night, and there will be some marketing materials for that. We are very well prepared. We've booked radio advertising with Heart Star and 105, which will encourage people and event organisers to follow the advice around Halloween. And ways of celebrating Halloween and Bonfire Night differently this year to reduce the risk of COVID-19 transmission. So, for example, people will be encouraged not to door knock for trick and treating, but to celebrate at home instead. And those radio adverts will start on Monday, the 26th of October. So we are working very hard to communicate on that. And in terms of Bonfire Night, we're working with the fire service so that, again, we have joined up communications and we're giving the same messages rather than different messages from the different organisations. So that really covers Halloween and Bonfire Night. In terms of Remembrance Sunday events, that's a little more complicated because you tend to find that each event is different. So we are again waiting for government guidance, but in the meanwhile, because we know that people are organising their remembrance events now, we're encouraging the event organisers to go to their district level safety advisory group, which advises on all events and brings the different agencies together to do that, and to share details with the safety advisory group. And we also provide general advice on events. We have that available on our website, and we can provide the sort of general advice of make sure that it's legal, check the guidelines, make sure that you do a risk assessment. So there's a mix of communication, general communication, but also with the remembrance events, encouraging organisers to use their district safety advisory group. And then that if the safety advisory group's worried, that comes through to public health. We look at the more complex events.
Thank you. Chair, can I just come quickly back on Halloween? Because in the absence of government advice, groups have been organising for at least the last month as to what they're going to do. And Liz, you said celebrate at home, but there are groups already organising things like putting things in the window and sending the children around, spotting them and getting sweets for doing so and things like that. And what they want is a kind of a sense check of, is that legal and is it safe?
So I think that that's very helpful feedback, and we'll make sure that we are putting, I think that some of those ideas sound like things that may come out, but we'll make sure that we do perhaps a bit more of a Q&A. I'll talk to comms colleagues on our website, so it's not just a radio advert to raise awareness, but also that we've got a bit more detail. And it's very helpful to understand what people are organising so that we can offer that sort of reassurance and Q&A on our website as well.
Thank you.
Thank you. Can I just mention, please, we've only got Liz for 20 minutes now. So, Nikki, please.
Yeah, so my question was also on Halloween, so I'm pleased that it's already been answered. And I quite like the idea of doing the window displays. Quick question is, do we know what our per 100,000 number is at this moment in time? Because I've not seen a latest update on that as yet. And in regards to encouraging people to go to the safety advisory groups, will the safety advisory groups will then update the relevant groups on the different guidelines subject to them changing before their event? Is that the reasoning for that?
So we do have our numbers per 100,000. We normally come out with that on a Thursday or Friday. So I think that will be on our Cambridge Insight website imminently. In terms of, and there are a couple of different numbers, because you have to make sure that you present the information at a point when you know that all the cases will have been reported, and they tend to trickle in over a few days. So that's why I'm not just giving you a figure, but we will publish the figure on our regular update on Cambridgeshire Insight, and I can circulate the link to the committee if not everyone's got it. So that, yeah, that is a yes. On the safety advisory groups, what they do is they just ask the organisers of an event for some documentation of their risk assessment, what the event's about, and then they will provide feedback and advice if there's anything that they feel. And it's not just for COVID-19, it would also look at other aspects of safety. So particularly for a Bonfire Night event, they'd be looking at a number of different aspects of safety, but they've incorporated COVID-19 safety into that process. So they'd look at the risk assessment and they would feedback any concerns or any changes that they thought needed to be made. And in some cases with COVID-19, they'd escalate to County Council Public Health for further advice.
Thank you. Linda Harford, please.
Thank you very much. So just one quick comment about the university situation and the addresses mix up. Having two large universities in Cambridge, I wonder if there isn't a reverse of that effect as well. So I wonder if somebody's looking at that, because we may well be finding that we should be benefiting from some cases being taken off, but having those two big universities, I'm wondering if actually the number that we might not benefit from, but might get as a result of that review, might more than outbalance the first figure. My question, please, is do we have any information about the current rate of testing in care homes? Has the issue that stopped them getting proactive testing for staff been overcome. Is that proactive testing now happening? Is it just for staff? And what's happening with residents now? Thank you.
Okay, so thank you, Councillor Harford, and I can answer on both of those. In terms of the universities that we have in Cambridgeshire, yes, we are in close communication with Public Health England, so we are getting the local data to do that adjustment, and we do get data on students who are at Cambridge University but may still be registered with their home GP. So we add the data in both ways. And as a fail-safe, we also are working very closely with both universities. So we will work directly with them to understand what their cases and rates are, as well as having to go through that national system. So yes, I can reassure you on that. On the care home testing, we are certainly aware that the care home testing, the asymptomatic testing has resumed. And those results come through to us in terms of, because care homes will let us know if they have a case amongst a staff member who's asymptomatic. So that information often comes through to us. So I'm aware that that's resumed. I'm assuming that for residents, it's the previous national recommendation that's less frequent than for the staff, because it can be more distressing or upsetting for the residents to have that invasive swab procedure. So they tend to do it less often for the residents. And the other thing that I can't absolutely reassure you on, that I can go away and feed back, is initially it was for certain care homes for older people and people with dementia, and I couldn't give you chapter adverse on whether that it extended out further to other care homes. So I'm happy to feed back on that outside the committee.
Thank you. I really appreciate that.
Thank you. Excuse me, Councillor Jones, please, Linda.
Thank you very much. Two questions really, very quick one. I think we had an exchange some time ago, Liz, about whether, I think you had some comms going out, a leaflet going out to all businesses, and they had to pull it because the government information advice changed. Has that now gone? Because certainly there are some businesses around the area I live in, which is, as you know, Mill Road, where people don't seem to know what the advice really is. So that's my first question. Do you want to answer that quickly first?
Yes, I'm sure it has gone. And it goes out through the environmental health databases in the district and city councils. So it really should have got to people. But if you want to drop me an email again outside the meeting with any businesses you're concerned about, then we can get environmental health to go and speak to them directly.
Thank you very much. The second one is about testing. And I've had several reports now from various testing centres saying that people who are not motorists, that is to say, who don't intend to arrive by car to Trumpling Park or Ryde or to Milton and so on, are not able to book a test. And it's only if they say they have a car, even if they don't, that they can then book the test. I've also had comments of people who've turned up, booked a test, turned up on a bike and been turned away. So I'm really concerned about this. I know that there are mobile testing units, and I think Councillor Massey was concerned that mobile testing units were coming, and we weren't given any warning about those, so we couldn't direct people to them. But it seems to me that there's a real confusion here. I mean, there are lots and lots of people who are living in and around Cambridge who do not have cars, and lots of people outside Cambridge who don't have cars. And I'm wondering what's going on here.
Okay, so I'll give you we don't directly run the testing centres, but I'll give you my best understanding.
Yeah, please.
So,
I realise that, but I thought you'd know.
Yeah, I know what I believe the current position is, because sometimes it does change. But we start with the drive-through centres, which are regional drive-through centres. So Milton and Peterborough Showground are regional drive-through centres, and they're not designed just for people who live in Cambridge or people who live in Peterborough. They're designed because they're kind of readily accessible, and they're expected to be for a wider group of people, and the expectation is that wider geography people will drive there. So they are referred to in national terminology as the drive-through testing centres. one of which is in Milton. The mobile testing units, certainly our experience with the ones in Peterborough, which is the ones that I've been closest to, is that they will accept people who turn up on a bike or who walk, providing that they've booked a test. The issue is, in terms of us not publicising them, is that when the pressure came on to testing nationally, mobile testing units, which had previously had a certain number of appointments for people just to walk in without booking, those walk-in appointments were stopped. And that was partly because lots of people wanted to get a test. And so where there were walk-in appointments, those local testing centres, mobile testing units were getting absolutely overwhelmed. And it was causing problems in the local area. So when it was no longer possible to attend the testing centre without booking, at that point, we stopped advertising them so much, because if you advertise, the risk is that people will turn up without an appointment, and you get the appointment by phoning 119 or going on the web and seeing where you can go. So that has changed, because people do have to book now. And clearly people can book a postal test. So people can go on the web or phone 119, and their choice is to drive to a drive-through, to book an appointment at a mobile testing centre, or to order a home test kit, and basically that's the position. And I think you're aware that we are now getting a mobile testing centre in the sort of Coldham's Lane area, which will be helpful for people.
Thank you. I mean, I think there might need to be some comms around this, some further locally. Because people are, I've had 3 or 4 cases where people have come back and they've been confused and they've been kind of angry about it. And I'm sure that they probably haven't done the right thing. But on the other hand, the reason they haven't may be because they've got confused about what they should be doing. And obviously they're anxious because they think they might be positive. Thanks very much.
Absolutely, that's really helpful, Linda. And we're about to start quite a big comms campaign on self-isolation, because we feel a lot of people have been confused about self-isolation. And it's really helpful to get your feedback that people are confused about the local testing arrangements, because we can work with the comms team and try and make sure that's sorted out.
Thank you.
Thank you, Liz. We're running out of time. Susan, please.
Thank you. Yes, the question of testing in care homes, it's good to know that it is taking place, but I wanted to ask, based on feedback from a couple of care homes, about inconclusive test results and whether that is an issue that we're aware of. The speculation was that was due to the time it was taking to process tests in the labs, and that was a problem for them. And the other issue I wanted to raise was around the workforce. You and your colleagues in the council, you referred to the heavy workload in 3.9 generated by the work around schools, for example. And earlier on, the additional funding provided by government to support local authorities in their COVID work, and I don't remember the title of that money, but I recall there was the intention was in part to support the workforce. And I just wondered if you could comment on that. Thanks.
Yes, of course, Councillor van den Ven. And on the first question, yes, I have also heard that there are some issues with inconclusive tests. It can be quite hard to take a test and actually get the right cells onto the swab. So sometimes it's because of the way that the test's taken. There may be other, because we don't commission that testing service, I couldn't comment on the detail of what you've asked. I'm not aware of it, but I might not be. We don't commission that service, so we don't get the detail. On the workforce and the test and trace grant, yes, absolutely. We are using that grant for a variety of purposes to deliver our local outbreak control plan, but part of that is to increase capacity in the different teams within the council, including public health, but also education, comms and so on, increase capacity so that we have more workforce to deliver. And we've also given funding to the district and city councils in order to provide support for their environmental health workforces that are also, as you know, working very hard and need capacity.
Thank you. And lastly, Lucy, please.
I'll try and be very brief.
Thank you.
I've got two questions, and Liz, if you want to reply afterwards to them both, we can do some stuff by email if you're in a hurry. But so the first is a comment really on the Halloween issue, which is that the things that happen at Halloween are, for some communities, a really important community event. And while I completely agree that knocking on doors is absolutely not a good idea at the moment, I think there is quite a lot that you can do for those events, because they tend to involve walking around in the streets. And given how much we're asking people not to do, I think if we encourage them to do the things that they can, it will make it easier for them when they're asked to not do things. So when we start talking about Halloween and our comms for Halloween, can we try and encourage and be positive about what people can do, because there's quite a lot that we can do. And I'm very happy to write to you about that, having taken small children out doing it relatively recently.
That'd be great.
That's the first point.
Welcome.
The second one is about universities. So the extra information that's come on universities is really important and really helpful, and there's lots of useful stuff there. I know that there are lots of people in our communities who are very worried about the students who've just come back. It does actually seem to me that that both universities have managed the return of their students relatively well, and that actually the students in Cambridge seem to have behaved very well. And I'd like to thank them all for that publicly. I think my next big worry is what's going to happen at the end of term. And I know there are lots of people who are worried about whether students are going to be able to go home for Christmas. I'm quite worried about the number of students who will not be able to go home for Christmas because they will feel that they're putting their families at risk, because it means flying to somewhere and they're not able to do that within the time. There will be far more students than normal who will have to stay at university whether they want to or not. And it would be very helpful at some point to get some feedback from the university about how they're going to support those students and what is going to be available both for the students and for the communities that the students are part of over the Christmas break, which will be different from the normal Christmas break, kind of regardless of whatever the national position is. Thank you.
Thank you. I think that's a really good point that we can raise with the universities. It's not something I think that we have really covered to date, but it is a very good point.
Thank you. That's fine then.
Great, thank you. Thank you, Liz, as ever. Please take care. Please try and find a couple of hours off if you possibly can. Thank you. We're asked to just to see what's going on, and we've done that. So thanks very much, Liz. Can we go back?
Hand over to Val.
Yeah, I think we go back now to item 6, please. Page 13 to 18 in your agenda pack. Public health grant funding for NHS commissioned services. And Val, if you could please provide a very short introduction and we'll move forward. Thank you.
Thank you, Chair. Yes, this is the second paper on the public health grant funding for NHS commissioned services. It's the same text that this year we've had an increase in the public health grant, and that increase is being assigned, and it's actually stipulated in the documentation that this should be set against the value of the Agenda for Change pay increases, which obviously affect some of our public health commission services where they employ NHS staff or NHS organisations. The grant increase this year was 6.6% in total. The initial grant uplift, which was amounted to £1,688,000, and that takes our grant for this year up to £27,248. The first paper gave an indication what we thought was going to be the amount we'd have to pay for Agenda for Change salaries, but we had to revisit that again with providers as it became clear that the increase which had taken place over the past 3 years, had played out over the past 3 years, and there'd been an incremental increase each year. So in fact, what we would be funding would take into account all those previous increases. So that obviously, the knock-on effect with that was that our cost pressure in terms of salary costs increased to the amount indicated in the paper, which was over £500,000. Interestingly enough, that means the actual real allocation for public health is a 4.4% increase, which is just over £1.1 million. So the detail is described in the paper on where those increases would be allocated, the different services. And so it's to ask the Health Committee to approve that. This is a key decision as it's over £500,000. And also to add that at the first paper that I brought to this meeting was that to say the balance from the amount we would put towards Agenda for Change salaries would be allocated to the obesity, or I should say the healthy weight work, which has started to take shape, which was mentioned previously at the meeting. Councillor Hudson, you're on mute. You're on mute, Councillor.
Thank you. I should know better by now. Thank you. Thank you, Val. Members, do we have any questions for Val on this paper, please? It's all very sort of, here it is, and it's all very good and understandable. So we have no questions. How's that, Val? That's the first.
Oh, I say thank you very much.
Thank you. We're asked to note the increase of the ring-fence public health grant and approve the allocation of funding to commission services to meet the cost pressures created by the increase in Agenda for Change salaries, which of course is the NHS salaries that we're coming to catch up on, set out in paragraph 2.2. And if anybody objects to that, could you please raise your blue hand? Otherwise, we'll take it as we all agree and move on. We all agree. Thank you very much, everybody. And we'll move on. Thank you, Val, to, excuse me, item 7, pages 19 to 26, the recommissioning of counselling service for children and young people. I'll welcome our good friend Raj and Carleen Allen. Carleen's the head of children and maternity at the CCG. I'd love to say how much we appreciate you accepting the invitation to take the time out of your busy schedule. Members, we have a maximum of 30 minutes on this. So, Raj, would you like to give a brief introduction, please?
Thank you, Chair, and thank you, Carleen, for joining me from the CCG. So, in brief, the paper is to enter into a Section 76 agreement with the CCG and to transfer the allocation that we had for children and young people's counselling services from Cambridgeshire County Council to the CCG. Currently, we transfer it to Peterborough City Council, who's the lead commissioner. So it's a three-way pooled budget from the CCG, from Peterborough City Council, and from us here at Cambridgeshire County Council. In 2016-17, the services were tendered and the contract was awarded to CHUMS. At that point, it was Peterborough City Council who led on the commissioning. This service has been in place since January 2018, and the contract is due to expire on the 30th of June next year. So there is a need to urgently put in place another service to replace this or carry on, whatever. But there is a need to go through the procurement process, and hence the urgency for this. The main issues with CHUMS have been that there have been lots of referrals in and lots of children and young people bouncing around the system because the system is so complex, and people are not clear which service to refer children into, and sometimes 5 referrals are sent for the same child into lots of different services. So through public health, we did children and young people's mental health needs assessment last year, which highlighted that actually there was a need to integrate these services more so that it could be a seamless service with better experience for children and young people. And we would like to have a single front door into the mental health services, which would then triage or put people into the right service, which is right for them, depending on their level of need. And because the CCG has a lot of experience in commissioning the rest of the pathway, and I'd like to, if we can go to the model at the on the last page, if we want to just quickly go through it, that model which says that we'd have a single front door with a lead provider model. And this is the Thrive framework, where we have the getting advice. Again, the emotional health and well-being service is commissioned by the CCG, and the children and young people's practitioners would become part of this service. So that's the advantage. Also, the online counseling service would become part of this. So children with lower levels of need would be through that outer circle. The next is the getting help, which is the CHUMS service, currently called CHUMS, which is where this counseling service fits. So it's sandwiched between two of the services that the CCG commissioned, which is and then the getting more help, which is the CAM8 service. And so it would make it easier if it was just one single pathway, so that children could be stepped up or stepped down depending on their need. So that's the first change, that we want to change the lead commissioner. And that is, as I said, the rationale for that is explained. The other change that we were proposing or looking at was the age range for the service. Currently in Peterborough, it goes up to 18 years. In Cambridgeshire, it goes up to 25. And looking at the data for the last year, 31 young people were accessed CHUMS during this year in the 18 to 25 year age group. So not a lot are accessing the service in that age group. And that may be because of the need for different types of services for them, which will be explored in focus groups. And Carleen may be able to talk a bit more about that. And I'll take questions, I think, rather than...
Yes, thank you.
Any more about it.
We start with Lucy, please.
Thank you. My questions are exclusively about that change to the age range. I think that changing the two other changes that you've outlined, the single point of contact, I absolutely agree that would be extremely helpful. I totally recognise the issue that you've mentioned about children, about people not knowing which bit of the service to refer into. So I think that single entry point from which children can be directed to the right area is very helpful, and that would be very useful. And I have no problem with the lead commissioner. That's completely fine. I am extremely concerned about the concept of moving the age range down to 18 rather than moving Peterborough up to 25. I think that there are quite a number. I'm astonished that the number of children who are referred in at that point is so small. I think there are quite large numbers of young people who suffer from mental health concerns and mental health problems around the age of 16, 17, 18, when they're under huge pressure at school from exams. The problem at the moment is that if you are referred, or quite often, if you're referred into the service at 17, there's an 18-month waiting list, by which time you then only get referred into adult services. And those services are simply not appropriate for many of these young people. So I am extremely concerned about the idea of changing that age range. I'm hoping that you'll be able to tell me that I don't need to be, but at the moment that is a massive red flag.
Yeah, thanks, Lucy. And I think Carleen, I'd like to ask Carleen to step in here, because there is some transforming care work going on about how to deal with these transition points and as you say, not have people falling off a cliff the moment they reach their 18th birthday. So there is a whole program of transforming care work. And I don't know, Carleen, if you want to expand a bit more on that.
Yes, happy to. So as Raj has alluded to, there is mental health investment money that comes into the CCG, which is focusing on looking at those transitions ages. What we've found is that with the children or the young people that between 18 and 25, the acuity of their condition tends to be beyond what this service can offer. And so actually what we need to do is use the money slightly differently in that transitions age group to focus on some of the more specialist services to be able to bolster up the support there. Having said that, the long-term plan does recommend that we should be looking at 0 to 25-year-old services as opposed to 0 to 18. So definitely take on board the challenge around whether we should be altering the Cambridge service or altering the Peterborough service. But there is only a certain pot of money, and at the moment what we need to do is focus the priorities of this funding to address the biggest need within this age group for the emotional wellbeing service. The older children, as I say, the complexity and the acuity will be picked up through the more specialist services.
So I have to say I'm not reassured by that, and I think I think that there's a real problem with young people of that age group not getting help early enough. And what you've just said about the acuity of the need implies that that would continue. I mean, I think that there's an absolutely urgent need to get more help into those teenagers at the earliest point we possibly can, so that the need doesn't become quite so bad. And my real concern is that if we reduce the age range, we will be doing that even less than we are now. So I have a real problem with that, and I think it's important to just note it. Thank you for your comments, though.
Thank you.
Thanks.
Thank you, Lucy. Linda Jones, please.
Thank you. And I'm afraid that I have a very similar concern to that expressed by Councillor Lessinger. I looked in the paper, really almost in vain, for a convincing rationale of why the cutoff point should be 18. And then I saw there'd been an insight report, which you gave us a link to. So I went and read the insight report, and that made me more worried rather than less worried. First of all, because the NHS plan priority includes a comprehensive offer for 0 to 25-year-olds reaching across mental health services. That was page 17 to 19. But secondly, because on page 11, it talks about where the prevalence is highest, and that's in the age group 20 to 25. And what it's saying is that 17 to 19 as well is very high. Also, it's saying that in Peterborough, there are 3 times as many, in Cambridgeshire, I should say, there are 3 times as many diagnosed mental disorders as there are in Peterborough. And I was really concerned about this because it seemed to me this issue of having a single service, a single entry point works well if you've got a whole set of needs that are broadly similar. But if you've got different needs at different stages in different parts of this contract, then I think you have a potential problem. So I am really concerned about this. And I think what concerns me most is the notion that this contract rolls forward, but we haven't really sorted out what we're doing with the 18 to 25-year-olds. If there was a contract alongside that, that would be fine, but there isn't one. And the issue, I can understand what you're saying about resources, but actually, is this an area where we should be putting more resources in? And if so, how do we do that? That's something we should be thinking about, rather than saying we're going to cut the 18 to 25 because we haven't got enough resources. So I do feel a real concern about this.
Yeah, thanks, Linda. If I can pick up the point about the needs assessment, which says, as you rightly point out, that the numbers are higher. So those numbers are based on population data. So it's just an estimate. We haven't actually gone and looked at numbers in Cambridgeshire and Peterborough. We've applied the national prevalence rates to the population. So because the Cambridgeshire population is higher than the Peterborough population, and then we take into account other factors. It's just, it's not an actual number. It's come from applying the national prevalence rate to the different populations, just the demographics of it. It's not actually looking at, and that's why the numbers are different. But in terms of, yes, I totally get it that there are more 18 to 25-year-olds who need mental health support, and that's the highest age group that need mental health support. But whether this is the right service or whether it is the more adult focused service is the question, I think, is and the transforming care, which is a service which bridges the gap between the adolescents and the adult service. So there is investment. I don't know if Carleen, you could talk a bit more about the transforming care funding and this is the right service is the question for us, I suppose.
I'm sorry, Raj, I'm not quite sure what you mean by the transforming care
So
funding.
the transitions bit, there is funding that goes into funding the transitions, isn't it, from the CCG?
So there is a transition service that's been funded through the CCG out of mental health investment standard money, which is supporting our sort of 17 to 25-year-olds to access services and get the need that they want from the more specialist services. There is also sort of lower intervention services like online support through Keep Your Head, but there isn't any service like this model for the 18 to 25-year-olds.
Okay, I thought there was adult IAPT services.
Sorry, you're absolutely right. There are adult IAPT services, which this cohort of children would be able to, or young people would be able to access, called improved access to psychological therapies. So absolutely, yes, that's in place for these children as well.
Yeah, so this is the lower level service for children, and then there is the equivalent for the older age group, is my understanding. So this is like the children and young people's IAPT, and then there's the adult IAPT. So there is a service alongside this for that age group, was all I was trying to say.
Sorry, could I just come back on one thing, which is that the report I looked at, they weren't talking about it in relation to population size. They weren't estimates, Raj. The figure 5 is a prevalence. It's their prevalence. So we're talking, you know, we're talking about being misused. We're talking about statistics here, not about population levels and potential. So I mean,
is this the needs assessment, Linda?
Well, let's take it outside the meeting. But no,
I think we all agree that there is a greater need in that age group. I think there's no question. I think we are all agreeing that there is a greater need in that age group.
Yes, but we're not agreed on whether there's actually a service that can deliver. That's what worries me about it. And what we know is that the group that's been hardest hit by COVID have been the under 24s. We know that, the 18 to 24s. So we're taking away a service that may be more widely used, you know, to come in line with Peterborough. And it seems to me a poor rationale for doing that.
Yes. Yeah. Yeah.
Thank you, Linda. Anne, please.
Thank you, Chair. I'm Vice Chair on the Corporate Parenting Committee. And as such, you know, we are responsible for all children who have been in care up to the age of 25. In actual fact, all county councillors are responsible for children up to the age of 25. I know this service is not aimed directly at children in care, but quite often you find children in care are the ones with the needs that need the most. They haven't got anyone else to stand up for them. And I couldn't understand why Peterborough couldn't come up to 4 to 25 rather than the other way around, because they also are corporate parenting. Surely somebody at Peterborough has thought about that. I would have been more reassured had it not been for the last sentence in 3.1, where it says further work is underway to understand whether these young adults could be accommodated within another existing service, and whether more broadly there are services with capacity that can cater for this age group. Until we know the answer to that, I don't believe we should change this.
Okay, yeah. So, yeah, thank you. Yeah, we take that on.
Thank you, Anne. That's a good point. Nikki, please.
I agree with everything that everybody has just said on this, so I'm not going to repeat anybody, but all I will say is be cautious about thinking about where the line between adult and young adult comes in, because the 21-year-old may not have the same maturity as another, and that's my concern, is that if we're looping everybody in at the age bracket of under 18s, there are some 19, 20, 21-year-olds, and indeed probably older, who are still mentally immature, that adult services would not be appropriate for them, and that would be my concern.
Yeah.
Thank you, Nikki. Linda Hartford.
Well, I'm sorry to preach on the same sermon, but all I'm going to say very simply is that we need to remember that young men in this age group, the prevalence of suicide in that age group, and I, for one, won't countenance anything that doesn't give me absolute assurance that anybody who might be moving towards such a big step or any other life-changing action is well looked after. And so I support absolutely everything that's been said by everyone so far.
Thank you. Susan.
Thank you. I suppose on the positive side, there is a concern that is quite clear and there's a consensus on, and I think we need to ask what the implications would be for not proceeding with a decision to see this paper through today. I share all the concerns that everyone's raised. I mean, we have posed a question that we can't answer about provision for 18 to 25-year-olds in.
Thank you. Yeah, I get it. We're all concerned about what we're going to do with the 18 to 25-year-olds. We don't understand the transition fund properly, or the online support, the improved access to psychological services. Excuse me, nothing's laid out for us to feel easy about going forward with this. Perhaps Lorna, do you want to come back on that?
Yes, I share I agree with Councillor Hay about the point where in 3.1 it just says, well, we don't know where these young people will go, maybe there's something. But also in 3.3, the suggestion that we would actually take the money that's currently being spent on those young people and use it on something else, suggesting that not only are we not clear where they would go, but there would be no money, additional money to provide the service for them under the new arrangements. On two other matters, 2.9 says that the current complex system with the plethora of providers will be simplified. It wasn't clear to me in the paper that was actually going to happen. It was clear there was going to be a unified front door, which I agree is a good thing, but it wasn't clear to me that the number of providers would be reduced significantly. And the other question I had was 3.5 talks about a lots-based model, and I'm afraid I have no idea what that is. Thank you.
Raj, do you want to come back with that, please?
So I think in terms of, I think we didn't answer Susan's question and the question about the 18 to 25-year-olds. So it's my understanding that if we resolve that issue and we bring back something to say what we're doing with the 18 to 25-year-olds, or that we're not going to change the age range for the 18 to 20, and for Cambridgeshire, we'll keep it at 18 to 25. Then that is one aspect of it. The other aspect was about the number of providers. I think the model would say that the lead provider would be actually deciding how to allocate the allocate where the other people go to. So I think there is a consortium of charitable organizations who would be able to provide place-based services for these young people. Be a question of then the lead provider talking to the different charitable organizations in the different localities about how to deliver in those different localities to meet the needs. But Carleen may have a better idea because there has been a soft market testing event recently.
Yes, so happy to come in there, Raj. What we're looking at through the market testing is we are in discussion with all the different local services that provide early intervention children's mental health at the moment, to bring them together as a consortium or an alliance of providers so that they are providing a service that still allows for the different health inequalities and the different types of intervention that may be required in different areas for the children, but that they are working seamlessly together so that we have that flow of information between the services and from the triage point of the first of the no wrong door at the front, so that we are making sure these children are not bouncing around the service. And that they are guided to the area or the provider that has the right service for their needs and the right interventions for them at that point in time. So we're not saying that we're reducing necessarily the number of providers. What we're asking is that someone has the overarching contract to keep a rein on the service, and that the smaller providers that are offering those very place-based elements are brought together as a collaborative so that information flow and communication is much better.
Does that answer your question?
Hang on, Linda, briefly, please.
Yeah, sorry, I just want to come back on that because I'm sort of slightly worried about it. It feels to me as if the providers are going to have to kind of organise among themselves, and therefore it's easier for the CCG and it's easier for the local authorities, but actually the burden falls on the providers. I hope you can assure me that that's not the case.
So they have been working together over the past few years, the organizations that are providing these services, the charitable organizations, they've come together as a collaborative over the past few years since CHUMS has been delivering the service. The local organizations have also been working together, and they've already come together as a collaborative to work on this.
And just to reassure you, particularly through the first phase of COVID, they absolutely all banded together and set up regular weekly meetings so that they could meet the additional system demand through this period. So they are building on that learning and those relationships that they've built to come together as a sort of overarching organisation to be able to move this forward.
Thank you. Susan, do you want to come back quickly, please?
I think we have been encouraging that for a long time now.
Yeah, absolutely. Yeah.
These problems were coming up with the currently commissioned service. I think it's been over the past 2 years that we've been encouraging them, and they've been thinking about it for a long time, and they've been coming together on their own as well.
Thank you, Rod. Susan, quickly, please.
Yeah, so it seems to me there is no consensus for approving this. I don't mean to prejudge the committee when we're asked to vote on this paper, but I don't see that there is a consensus on supporting the paper in its current form and highlighting the 18 to 25 year cohort, which I think Councillor Hay, expressed on behalf of us as corporate parents. So I think we need to consider, Ben,
I think
where
if
to
I can,
take this.
Susan, if I can come in there, I've got about, I don't know, 300 things going on in my head at the moment with this. Basically, I think most of us are okay with the paper, apart from what we're going to do with the 18 to 25s. And there's nothing in the paper that makes us easy that the service is going to be there if these people require it. How old are you when you become an adult? Well, that all depends on your mental health and your maturity. You know, I know some 45-year-olds. I certainly know a 33-year-old who needs to grow up sometime. That's my son. You know, so will the service be flexible? So if a 24-year-old can go to adult services, he will. If the 24-year-old is not mature enough, then we look after him with this service. It doesn't explain that. I don't think we need to vote on this. I think perhaps we should ask the paper to go back and come back next meeting to see if we can resolve the 18 to 25-year-olds. Would you all be happy with that? Put up a blue hand if you're not.
Sorry.
Yeah.
No, may I please, can we clarify that? I think it has been raised that we should not change the age range in Cambridgeshire. So I think that needs to be part of the consideration.
The issue is the 18 to 25-year-old range, isn't it? I mean, whether we change the range for this particular service, we can only do that if we know there's a service that will look after the 18 to 25-year-olds to a standard that we want them to be looked after. That's what we're saying, isn't it? That's exactly what we're saying. So let's not vote. Let's not do anything about that. Let's ask Raj if you can go and solve this tricky issue, Raj, with your team, please. Yeah. Rob, could we pop this on as a special item next meeting, please?
And can I check, are we okay with the first question, which is about the CCG being the lead commissioner and having this model of delivery?
I mean, no one's objected to Section 76, have they?
That's all I wanted to check. So it is the age range that...
It's the age range, yeah. The Section 76 is fine. It's the age range. It's the 18 to 25-year-olds. So if you can come back next month and reassure us that this is going to be okay, I think we'll be okay. But we can't do it as it is, I don't think.
Okay.
All happy?
Yeah.
Great. Thank you, Raj.
Thank you.
Thank you. Hey, section number 8, please. Oh, it's Raj again. Don't go away, Raj. And Helen's there, Helen Freeman. Hello, Helen, nice to see you. Supporting children, young people and families during COVID-19. Helen, of course, is the team commissioning manager. I think is going to introduce the report. Is that right? Helen, you there? Oh, she's just coming. Helen, can you hear me?
Yeah.
Sorry, when I was changing from being somebody who was attending to participating, it went a bit strange there for me. But yes, I can hear you, Councillor Hudson, and I am now.
It's nice to see you. Would you like to introduce the report, please?
Are you okay, Raj, if I introduce this?
Oh, Raj can introduce it. I thought you were. Raj, you're on mute.
Yeah, happy for Helen to carry on.
Okay, let's go then. Helen, please.
Brilliant. Hi. So this report has come to you today because I brought a report, I think it was 3 months ago now, when we were just giving you an update in terms of the impact of COVID on children and young people. In that report, we had said that we were doing some work as a system to identify any groups which were particularly affected and had particular risks, and what we were going to be doing as a system to mitigate those. So that is what is laid out in the first part of this report. I've also taken the opportunity to also give you an update in terms of where we are in terms of the Best Start in Life programme. As you'll know from kind of previous papers, the Best Start in Life programme is a programme of large-scale change and working across the system to work in a much more integrated way to join services up for families. And obviously, doing that kind of development work is challenging with the current capacity of the system, but we are moving ahead with that, and I thought it would be useful to kind of keep you updated on that. I'm aware of times today. I think that probably quite a lot of it is self-explanatory as we go through. There may be areas that actually we've moved forward on since this report was written, because obviously we're in an ever-changing environment, but I wonder whether it's probably easier to go straight to questions rather than me reading through what you've got in front of you.
Absolutely, because we've all read the report. Thank you. So let's start with Councillor Jones. Linda, please.
Thank you. I'm just fretting about a couple of things in this report. One that I think I always bang on about, which is you talk about responses, but have you got any idea of sort of levels of need emerging? Have you got, this is a completely statistic-free paper. So you're saying these have been put in place, these have been put in place. We haven't got any idea about what the uptake is, what the levels of need are that are emerging and so on. And you talk at one point about families with new needs calling the support service. Well, if that's the case, what are the implications for Best Start in Life then? Are these just COVID-related calls, or is it unmet need that's emerging? And if it's unmet need that's emerging, what are you going to do next? So I really don't feel the learning has come out. It's being done, but it's neither the statistics nor the learning are coming out in this paper.
Okay, so if I answer the first part of that, which was about kind of understanding that in more of a statistical form, I guess the issue is this is sitting across lots of places. And what we can tell you, and we can kind of put more of this information when we bring the Healthy Child Programme stats back, when we're looking at kind of the next quarter updates, is in terms of the impact it's had on that service, which obviously is a very large service. What we are seeing is a large rise in demand at both the Universal Plus and the Universal Partnership Plus level. So that is, we are doing a lot of work in terms of really understanding that, so we can bring that information back to you. But early indications are showing that a lot of that is because we have families who would usually have had a lot more support from their support system, so from their wider family or from communities, who are now asking for a lot more support from the health visitors and the school nurses. So we'll definitely bring that information back when we bring our next kind of quarterly report back to Health Committee around that. We're seeing, as it says in the report, a lot more people accessing our services for advice. So the call us number for the Healthy Child Programme has seen a 5-fold increase in terms of families accessing. We do have information about what those issues are, so we'll make sure that we can kind of get that to you. It's primarily around issues to do with infant feeding and child development is what's coming through mainly on that. And I think that's also the main areas in terms of the text us, which has also seen a significant increase. So we're getting information in terms of where the pressures are on the service in terms of access. In terms of the other question you were asking about kind of those families which we didn't necessarily know before, that we are seeing. That is a really interesting question, and we're doing a lot of work in terms of the whole system to understand how people are becoming vulnerable who maybe weren't vulnerable before. So we're looking at that in collaboration with the system across in the vulnerable people's group, with district colleagues, etc., to understand things like what is the impact on the huge rise of universal credit claimants. So one of the things we're seeing are people who are coming into our services who've never needed to understand how to access kind of financial support, how to access kind of those services where in normal times when your job was secure, you were okay. So we're working alongside our district colleagues to kind of have better understand how we can identify and support those families, but those are the kind of families coming through. So it's not necessarily new types of need, but they are families who haven't traditionally needed to access support services who are finding us. I hope that answered the questions.
Thank you.
Thank you. Lorna, please.
Thank you. Yes, I think this report would have benefited from some more detail rather than simply words like significant and a large number of and so on. And I think we need to get a bit more under that. I wanted to ask firstly about breastfeeding, because we've already, it was on page 30 of the agenda bundle, we've already had previously reports about the low-ish take up of breastfeeding in Finland as being an issue, and a very clear, again, sort of geographical divide between different districts on that. And I wondered whether that was made worse as a result of the pandemic. And we did say we would have something back to this committee on breastfeeding support. So I'd want to know about that and what's happened about the inequalities between districts as a result of COVID and different kinds of take up. And my second question is really the top of page 35, talking about the recovery phase. Does anybody really believe we are in the recovery phase? Because I don't think there is a recovery phase, and I'm getting a bit worried about all these reports that seem to regard COVID as linear. You know, we've done that and we're out of it now and it's getting better, and it's not like that. It's not looking like that, and I'm a bit worried that this assumption of over now we've just got to recover is being embedded in reports, and I'd like to ask officers whether that is something they actually believe.
I agree with you, Lorna. It doesn't look like recovery, but that's the NHS as well. We are trying to get more people back into routine immunization, screening services, all the rest of it. So I think I agree, it doesn't feel like recovery. We are still very much in reactive mode, but one can only hope.
And if I kind of pick up on that second question first, I will then come back to the breastfeeding question. I would agree with both of you. When we talk to our providers, when we talk across the system, we talk about response and recovery in both of those. And I think in terms of some of the areas where we are potentially seeing some recovery, obviously in terms of children, we have children who are back at school. And so we are looking at how certain services are, in a sense, looking at going back into a recovery mode. We're looking at how we can have more support going in around the schools, but that absolutely doesn't take away the fact that we are still responding as well in terms of where we're planning. And I think that's really helpful to continue pointing that out, because we are still in this situation and we are looking likely to be kind of continuing to have to respond and be flexible for a while to come. So in terms of breastfeeding, so we're looking at the data that's coming through. Finland for us is complicated because a lot of that data also sits outside. A lot of our women are delivering in the Queen Elizabeth. But what we are seeing at the moment is a strange kind of mixed picture, that actually in some areas, and it seems to be the north, it seems to be in Peterborough and Finland, although Peterborough Hospital are kind of still doing some work in terms of looking at their data on this. It seems to be breastfeeding rates have increased, or definitely did increase during the first quarter of lockdown. And it was felt that maybe there was something to do with being at home, having that time with your baby, having time to give to breastfeeding. But whatever those reasons are, we do know that we still have a significant inequality in terms of the rates of breastfeeding. So what we have is that we have a new contract with the NCT, which has been running in Peterborough for a while, but now from April is also covering the Fenland area to add peer support into the mix in terms of the support that they have from maternity and the Healthy Child programme. Now, despite the fact we've been in very strange times, mobilisation of that work in Finland has started. Peer supporters have been being recruited and trained. Work has been going on in terms of how that links to the hospital. And just to kind of give you an an idea of how that works, as well as running kind of peer support groups. They also link to the hospitals in terms of identifying women there who would like to have calls when they're home for a couple of days to be able to proactively call and support women. We've been able to be providing quite substantial amounts of breastfeeding support via video conferencing, so via Attend Anywhere, but also when we are aware of a clinical need, there has been face-to-face support that has happened safely as well. And as I said before, it has been the top topic that's been coming through in terms of our caller service.
Thank you. That's good news.
Thank you. Helen, just a quick one to side. I can remember a little while ago, some months probably, about a new breastfeeding clinic that opened in Wisbech and Fenland. Is that? I assume that's still going well.
So at the moment there aren't the face-to-face clinics, but there were new face-to-face clinics that opened in Wisbech in March. They were becoming established. They were being run as part of the Healthy Child programme. They will kind of come back when we're allowed to do that safely, but we're not able to offer kind of drop-in clinics at the moment. It all has to be by appointment only.
Yeah, okay, thank you. Lucy, please.
Thank you. I've got a couple of points. The first one, just on the recovery issue. From what Raj was saying, it sounds as if the NHS may be partly using that term to refer to the restoration of services which had practically ceased during the lockdown. And I think if that's what they mean by recovery, then we definitely need to have recovery because we need those services to be back and up and running. It might be helpful if it was made clear that that's what's meant by recovery, rather than the fact that the pandemic might be on the way over, which it clearly isn't. So I think maybe it's about just clarifying that that's what's meant by that term in these papers. So some of the issues that I had around that the paper sort of identifies a problem but doesn't tell you anything about the solution or what's being done about it have already been raised. And I absolutely agree with the point that particularly that you say that there are these families who haven't been in contact with your services before and that there are new needs, but you haven't told us anything about what you're doing about those new needs. I think you said that you would bring another paper to explain what's happening about that. And if that is the case, then that would be enormously helpful. And I would very much support that we need some more information on that to come to the committee, because there is clearly rising need out there. And I think we need to be aware of how it's being met. The final point, the question I had, which I think hasn't been raised, was about domestic violence. Which I think has also been a significant problem. And I'm extremely concerned that as we go into the winter with the potential of more lockdown of some kind and less ability for people to get outside with their small children, that will become an increasing issue. I'm already aware of a couple of cases where it's been very difficult for women and children to find alternative accommodation. So I'd just like some reassurance from you that that's something that you're aware of, and that people will be reassured as much as, I mean, that if housing is needed, it will be found. If people need safe places to go, it will be found. And that message is getting out there very clearly to anybody who might be in a position of threat, because I'm extremely worried about what might happen this winter in some families. Thank you.
Okay, now Lucy, I was trying to scribble all of that down, so if I forget one, please do nudge me afterwards, because I might I already think I've missed one. So one of the questions was around what are we doing about the new needs? So one of the things I think that was in the paper is, if they are a family who isn't known to services previously, and we're not having a universal opportunity to go and actively find them, then one of the few kind of areas that are open to us is to be really clear about how people can access us. So that's been our first way of doing that, is to kind of say, well, how can we make it as clear as possible for families who may not have had to access these kind of services before to know they're there. So there has been lots of work in terms of comms that has happened jointly across the system. We took part in the Keeping on Track to let parents know about where support was across early help, etc. In the summer, helping people to start to think about kind of what their families might need and where that support was. So there's a lot of outreach. We're now having some really interesting conversations with some of the districts, and particularly have some conversations with Hunts about, are there other ways, is there other data in the system that might give us some warnings about families where they may be starting to have various issues, particularly looking at what they know in terms of new claimants, in terms of people who are coming in for housing, and how we can be a bit more kind of clever in terms of understanding, if you are a family who is a new claimant, if you are somebody who's having an issue to do with housing, how can we say, and as a family with children, what else might you be entitled to? How else can we get that support? So how can we link up the service that we have in terms of health visiting, but also others in terms of the wider partnership we're working with in Best Start in Life, with some of that data and that intelligence which is coming through from some of the districts where people are presenting in terms of need financially. So that's a kind of an active conversation that has started in the last couple of weeks that I've been involved in alongside our provider, to say, okay, we can be as loud as possible about where the services are, but is there another way of finding these families who might have their circumstances changing? So that's one of the things we're looking at. And another question you were talking about was around domestic violence, and this is something that we kind of are aware of from our social care colleagues. In terms of the cases that are coming in, we are seeing a rise in terms of there being domestic violence cases. And one of the things that we're looking at is how we can make sure we're increasing the kind of eyes on children. So one of the things we've been particularly looking at in terms of the Healthy Child Programme is, we know domestic violence and that kind of relationship stress is particularly acute during that kind of pregnancy and first year of life. So we're looking at how those touch points that we can make sure we have eyes on. So as much as possible, making sure that all children get face-to-face, or at least get kind of that via video conferencing. We've just had a look back in all of the babies born during lockdown to make sure we have had eyes on those babies at some point, either via a new birth visit, an essential weighing clinic, or their 6 to 8 week check, and to follow up any that we haven't. We've got that down to just 2 babies that we can't account for in terms of face-to-face, and that is going to be the cornerstone of how we work moving forward, is making sure that even those babies where there haven't been particular vulnerabilities picked up, somebody has seen them at some point, to be able to pick up on some of those cues in terms of what might be going on in the home. And I think there was something else, and I can't remember what it was.
It was to do with housing, but I think I think that sits across so many different areas. It's not necessarily your responsibility. It was to do with making sure that there are very clear messages going out that if somebody is in a dangerous situation, you will find them somewhere safe. Yeah,
and there has been, we've been sharing that information as widely as we can, and kind of working as part of that partnership. But yes, of course, it's an ongoing message that we need to make sure is out there.
And it probably links to Val's next paper about the homelessness. And
yes. Thank you very much, Helen. That's very helpful. I still think it would be nice to have some more information at a further meeting, but that was extremely helpful answer. Thank you.
I assume you meant me, Peter. You're on mute.
Yes, Susan, sorry.
Thank you. Nice to see you, Helen. I just wanted to ask about baby weighing. I assume that the baby weighing must have fallen away largely during lockdown if it was available only by appointment. it would be useful to have some clarity on that. And also, could you explain a little bit what is meant by self-weighing stations? There's a reference there. Thanks.
Yes, actually, when you say it like that, it makes it sound like the babies are able to weigh themselves, doesn't it? Which obviously is not the case. So one of the things it is worth pointing out is that the Healthy Child Programme did continue all of the way through COVID. In terms of our activities, face-to-face was reduced and is kind of being brought back. But just to kind of say, all of the checks were offered as part of the Healthy Child Programme. So in terms of baby weighing, obviously, right at the beginning, what we did was we said, look, we can't have these large baby weighing clinics happening. So they were closed. But what happened almost straight away was we replaced them with a series of what we called essential baby weighing clinics, which were initially via referral and appointment only. So this was where there had been particular concern, either from maternity or health visitors, so that there was a safe place for families to go in and book an appointment to be weighed. What has happened is they have extended so that we are now have a situation where we have weighing clinics available across the county. They are all by appointment only. But for all babies at the new birth visit, if they haven't had a full home visit as part of that, which a lot of them would, especially if they were first-time parents or vulnerable, they would all be invited to go into, to make an appointment to go into one of these clinics to have their babies weighed and a physical examination happening. And if parents are concerned, they can call the Call Us number and they will be told how they can book an appointment at one of those clinics. As I said, they are all appointment only. So in terms of self-weighing stations, this is something which had been brought in at child and family centres prior to COVID, and now child and family centres are reopening. They have now reopened in a number of places. This is where a parent can go in and use the calibrated equipment to weigh their baby, and in a number of places there's also support from somebody at the Children's Centre who can help them to understand that and plot it on the growth maps, etc. These are again by appointment, so people make an appointment to weigh their baby so that that equipment can be cleaned between use.
Thank you. Members have been asked to comment on the progress made to date in responding to the coronavirus pandemic, and we certainly have. And we look forward to catching up with Helen and Raj in the next couple of months for an update, as Lucy mentioned. So thank you very much, people. Can I please now move on to number 9 on your agenda, pages 35 to 44. And our Val is back. Hello, Val, again. With Val is Sue Beecroft, and Sue's the housing coordinator for Cambridgeshire, Peterborough and West Suffolk. Busy lady. So a special appreciation, Sue, for coming today out of your busy schedule. So Val and Sue, can we have a very short intro, please? And then we'll go straight into the questions, because we've read the papers. Thank you.
Okay, thank you, Councillor Hudson. And I'd like to say thank you for Sue for coming along. She is my go-to person on housing. And does really is extremely helpful, and we've worked together throughout the COVID situation, if not before as well, but particularly so through COVID. This paper was in response to questions raised about how the changes that have occurred in the services that support the homeless population during COVID, how they could be maintained. Certainly housing, I think housing and homelessness, quality of housing, homelessness, I think everyone is aware the negative effects of these upon health, and it is a public health issue. And for once, I think perhaps COVID has had a very positive effect. It's very rarely you can say that about COVID, but it has shone a very clear light on the needs of homeless people, and has brought changes in terms of how they are housed and the services that they receive. The paper describes the response to COVID in terms of homelessness, the government requirement to take homelessness people off the streets and provide housing, and the collaborative work that then led to between housing services and a range of health, social and voluntary sector houses and public health commission services, particularly drug and alcohol services. And the feedback that we've had from the homeless cohort, that this has really seen, they've felt there's an improvement in the services they get and also in their health and well-being. Of course, and again, we relate to perhaps when we think about recovery, that isn't appropriate. And I think the immediate question was for people working in this area, how are we going to maintain those changes in services and how they work with the homeless population or people in poor housing into recovery? I think it's more now about this situation is continuing. How can we continue to maintain those improvements for the homeless population? And there's lots of details in the paper in terms of the improvements that are put in and where we think are the areas that need developed and the opportunities in terms of additional funding. And Sue is best placed to talk about these, including the drug and alcohol, which my team has been working with her on. But there are some big questions that still remain, which will present challenges going forward. One in terms of evictions and restarting. I think the continued pandemic and the impact on employment and the economic stress that is presenting increases the threat of eviction and homelessness. And I think we've described in the paper about the improvements in service delivery in terms of pathways and so on. But I think there's some the area which we are primarily concerned about is mental health services, which was a problem before. And there has been some development of this in response to the pandemic, but it's still an ongoing issue. And also, for me, primary care as well. And I think there has been developments and some improvements, but how we can make sure that is across the whole of the county as well. And there has been work that's been undertaken by the CCG to look at this, but the concerns remain. And Sue, would you like to add something to that, particularly from your sort of housing perspective, I guess, because you have such a granular understanding of it?
Thank you, and thank you for the invitation to come along. I think everything that Val said is correct. We've seen some quite marked improvements in the health of quite a lot of homeless people who would have been on the street because they've had decent nutrition during the lockdown while they've been in the emergency accommodation. And that's had a really significant effect, which has been noticeable to the voluntary and charity agencies who have been delivering the food to each of those units of accommodation. So obviously it goes without saying that we're enormously grateful to the voluntary sector for that support where they've stepped in. Because quite a number of people are now registered with the GP who were not registered before, that means there are more people who were sleeping on the street who now can get access into the services they really need, mental health and drug and alcohol services, that was already mentioned. But there are other improvements in health where there's been increased hepatitis C testing, quite often a condition that lies underneath the surface. People just feel unwell, but getting that testing done and managing to find some people who can be treated with such an effective treatment schedule for Hep C has been a real step forward. Though the numbers are low, that's significant for individuals. So we've taken quite a few bidding opportunities. The districts have taken a lot of bidding opportunities on the housing front, capital and revenue for both buildings and support into housing and securing more private rented housing. And of course, the CCG, the drug and alcohol team have made bids in to get increased provision and also to link in with the social prescribers across the whole of Cambridgeshire and Peterborough. So these are good step forwards, and these will in a way increase pressures because there'll be more people needing to access those services, but those services will be getting to the people who were without those services previously, not because they were blocked, but just because they just didn't have the wherewithal and the help and support to get access to those services. So there's a few gaps that have been pointed out in the report, one of which we'd love to work on, which is about tuberculosis screening and testing, and obviously eventually treatment, preventing rough sleeping in the future, now that we've got a kind of toehold on a far smaller number of people who are on the street. There are still people on the street. Some people are leaving the emergency accommodation, but trying to break into that cycle of people entering street life is really important to us. And the County Council commissioned a report that's just about to come out, which is about transforming the homelessness system across the whole patch. So that should help by working between the different agencies, social care, health, mental health, etc., to try and change someone's pathway where they might have ended up on the street. So that's probably enough from me, I would imagine, at this moment, but I hope that's helpful.
Thank you, Sue, and thank you, Val. Members, questions? Linda Harford.
Thank you very much. Thank you, Sue. It's so nice to see you. And everything that I'm going to ask, I don't want you to view it as being anything less than very positive about what you have done during this very difficult time. But I am concerned that possibly some of the resources that you had for being able to house people are now shut off to you, as there's been the efforts to reinstate the economy have been made, and I'm just wondering what impact that's going to have on you continuing this fabulous work. And also, I have to say that I was really interested to look at table 1 in the report and look at the investment that's being made. And I was a little bit disappointed to look at the combined investment on the part of East and South Cambridgeshire and Huntingdonshire compared with Cambridge City on its own. Now, their needs obviously are much greater than ours are in the rural areas, but nonetheless, when I look at 250 nights of temporary accommodation under spot purchasing, when I think about that, what that can actually do, it makes me think, well, you can possibly look after 4 people over a period of time, or else you can give a lot more people just some help for a couple of nights. And what do you do with them after that? Please don't think that I am in any way dismissive of all the hard work that you've done. But I would be interested to know how you're going to be able to continue this. Thank you.
It's definitely not offensive questions in the slightest. They're really good questions, that's fine. So the first one is a concern about the resource for housing people. Like, I think you're alluding to hotels, B&Bs that might be opening up for business again. So each district where it's used particular emergency accommodation has got a plan to try to reduce the use of the different bits of emergency accommodation. So there have been some hotels that, for example, in Peterborough have been used and then have stopped being used, but there's been a sort of contingency plan, and each district has got a plan for where they're moving people from and to. And the individual people within each of the hotels also has a personalised housing plan. That means they've got a pathway that they then can get the sort of supported housing or whatever it is that they need to come out of those hotels. So there's definitely a plan there, and I don't think it's the concern of, at one point there was definitely a concern that the hotels would all want to open again. I think it was around the 1st of July or something like that was a date that kind of seemed to be set. But we've managed, well, the individual districts have been wonderful in negotiating with the hotels and B&B owners to extend that, to have a slightly different agreement maybe, or where necessary to move people out and into a different form of accommodation. So I think coming forward to the winter, each district had to meet with the MHCLG liaison person who keeps in contact about these plans to make sure that there is going to be some ongoing provision as time continues and as we approach the winter. So then if I can move on to the second question, which is about the investment. So this is about the next steps accommodation bids. Peterborough, Wisbech and Cambridge put in more significant capital bids for building and securing accommodation, whether it be the what are they called, the modular units in Cambridge, or Peterborough was bidding to try and set up some new houses in multiple occupation, small ones that would be COVID friendly. What happened was, with the report that you got, unfortunately the timetable wasn't brilliant, so we got the results of the revenue bids that have been put in, and they were all successful. So most unusually across Cambridgeshire and Peterborough, everybody got all the revenue funding they'd bid for. Huntingdonshire, South Cambs and East Cambs that you highlighted only bid for revenue. They got all that money because the capital part at that stage had to be spent, and you had to be on site with any building by the 31st of March. The MLHCLG advisor said for Huntingdonshire, South and East, they weren't convinced that they'd be able to spend that capital money, and they preferred that they concentrated their bid on revenue funding, and that's mainly landlord incentive payments to get people into the private rented accommodation. The 250 nights was a very clever move as a sort of a bid that would help them cover the costs of their winter accommodation. It wasn't clear whether the districts were going to continue to get separate funding for their winter provision. So they put that bid in. This is why their bid is slightly different to the other districts. So so it doesn't sound very much, but the 250 nights is for anyone who needs to come in under the severe weather emergency protocol. So I hope that helps, and hopefully that sort of shows you the balance. I think it is reflected in the numbers, in that the larger numbers of people who've gone into the emergency accommodation are Cambridge, Peterborough and Wisbech. The other three districts have a number, but not such a large number.
Thank you so much for that, Chairman. Through you, may I come back? I absolutely understood what was in the report, and well done for all the bids being successful. But I still find it disappointing that those three districts were not able to come up with, the work that, you know what my background is, the work that we were doing on modular units 2 years ago. Makes it really disappointing for me that they weren't able to get that done. But I won't take committee's time up or say things that really you don't have any control over. There are things I want to talk about separately, if I may.
Can I just add one more point, Chair? Would that be all right?
Just one more point, please.
So there's 3 further years of Next Steps funding. So they may not have been successful in year 1 that ends 31st March, but there will be opportunities to bid further in a further 3-year programme. So don't be downhearted.
Oh, thank you. Thank you very much.
I promise the success, but there'll be it, I'm sure.
Thank you, Val. Thank you, Sue. Thank you, Linda. That was a really good question. I think it's covered everything anybody else may have wanted to ask. So Val, Sue, thank you very much, and thank you for attending. Thank you, members. We were asked to consider that information provided, which I'm sure we have. And now, item 11, please. Pages 45 to 50, the quarterly liaison meetings update report. I don't think we need an introduction to this, Kate. It's all laid out in neat summaries, which members will have read. So I'd like to go straight to members to raise any questions or comments, please. Thank you, Lorna.
Yeah, my question was about, and I don't know whether Kate can answer. Oh, am I muted? Can you hear me?
No.
Oh, right.
I can hear
Okay.
you.
A message came up saying I was muted. I don't know whether Kate can answer this, but it's a comment in the page. Where are we? Page 50, and it's the CUH liaison report back. It's a comment about testing people before elective surgery, and the implication of that comment is that the hospital themselves are testing patients prior to them going in for elective surgery. I have a constituent who is going into a hospital in London for elective surgery, who has been told basically that she needs a test before she comes in, but she's on her own and it's up to her to organise one. And of course, she's contacting the go and get yourself tested places, who tell her, well, as you haven't got any symptoms, you're not eligible to come and get a test. So I wondered whether this comment about CUH meant that there was a regular and accepted practice of hospitals organising their own testing of patients before elective surgery, and the London hospital that my constituent is going to is somehow an outlier, or whether it's very much up to individual hospitals how they do this.
I believe it's up to individual hospitals, but actually my first thing is point that I need to make is I wasn't at this meeting, so these are based very much on the councillors that attended. So that's Councillor Jones, Councillor Van de Ven's notes, and Councillor Harford's notes. But from experience with Addenbrooke's, I do know that they are testing. This is personal experience before surgery. But that's not necessarily elective. In both my experiences, it's been emergency surgery. I don't know whether or not Councillor Van de Ven, these were taken from your notes, so whether or not you can recall the conversation.
Help. I don't remember.
So it is literally just taken from your notes. So I'm assuming, because I know that they are testing for in the hospital for emergency surgeries. So I'm assuming that they do test for elective as well. They're testing visitors as well.
Shall we go and shall we lodge
go
this
back,
question
yeah.
to get it right?
Yeah, I've spoken to Roland sort of on a one-to-one basis a little while ago, and he was saying all elective surgery, when it goes ahead, they ask the patients to self-isolate before they go in, and then they are tested when they go in.
Yeah. Yeah, I think they are.
That's what it says in my notes too. So I think that's right.
Yeah.
That's great. Are there any other questions, please, to Kate? Thanks, Kate. Lovely report, as always. We've asked to agree the content of the report, and we do. So thank you very much indeed. So page item 12, the agenda plan and appointments to outside bodies. You've read the current agenda plan. Rob, is there anything you need to add?
Just really the two reports requested from the meeting today. That would be the additions, because obviously we've got quite a large agenda for the next meeting in that we've got three presentations with regards to scrutiny. So further reports on the services for the 18 to 25, the request there, and also supporting children and young people update were two definite reports to come back.
Yeah, we need Raj to come back with the issue solved about the 18 to 25s next month. That needs to be slipped in next month.
Yeah, that needs for November, definitely.
Yeah.
The other one, I think.
The other one could wait until next time if necessary. Yeah, Susan, do you want to say anything, please?
Yes, please, Chair. I wanted to ask a question about the timing of reports that come to us. I wondered if we could have the Liz's COVID-19 update report, say 48 hours in advance, just to make sure we have enough time to really read it properly and sort of find that balance.
Yeah.
And the other question, relates to the timing required for reports to the lead member meeting, because I think we are now cutting it so fine, because I guess there's a requirement for us to meet 3 weeks before a meeting, a committee meeting. Anyway, I feel we're cutting it too fine, and we need more time if we're going to be an effective first, have a first read of these reports to tease out things and ahead of committee.
Okay. Let me answer your first question. I'll speak to Liz. I have spoken to Liz. She gets the report out as soon as she can. She's really busy, and she likes to get the absolute up-to-date information for us. But I'll talk to her again. But we have to remember she's somewhat busy. Kate, do you want to come back and reference the other reports? We can only get them when we get them. I know that.
Yes. Yeah, I mean, clearly everyone is incredibly busy at the moment. So I do apologise, because in the past I've normally got them out to you about a week before, but I think we are all very much kind of running almost two different jobs, really. And certainly Raj and Val are incredibly busy. What I will try and do is see that you've got them, perhaps if we can make sure that you get them before the weekend before the meeting. Which will then so it may not be quite a week, and in some cases we are having to move the advanced briefing to 2 weeks before the next committee meeting, because we've actually got quite a short period. So December's meeting is very early on in December, and you'll have only just had your November meeting. So I've moved the advanced briefings around a bit, just to give you a bit of space and a bit of understanding as to which papers you're reading, because you'll be reading papers for December, having not even had November's meeting. So
thank you, Kate.
That's just to do with scheduling.
Yeah, that's fine. Whatever you can do with the papers, we'll be grateful. But we also know how hard you're working on other things, so thank you for that too. Linda Jones. Linda, please.
Oh, thank you. It was just to raise the issue. I wasn't quite sure what Rob's second paper was. Obviously, the first one is the counselling service for children and young people, which has got to come back next month. I wasn't quite sure what the second one was, but I do think the dental service needs to come back sometime early next year.
Yeah, it will do.
Because I think none of us were terribly comfortable with the strategy going forward in particular. So I think if we can have that for maybe January, maybe I'm not sure, but can that go in? What was Rob's second paper coming back?
I can't remember what Rob said, but as for the paper on the dental services, that will be in either January or February next year.
Lovely.
Rob, could you just explain what your second paper to come back was again? Because
well, I'm trying to, without seeing my notes and going back on it, there was more information required on the supporting children, young people and families during COVID. Further updates, I think.
Yeah, that was Lucy's. Lucy asked us some more information. Yeah. So that can come in.
Okay.
December / January, Rob. Yeah, that's right. Yeah. Anne, please. Anne.
Were we having something in November about the public health grant and healthy weight programme? Obesity.
Healthy
that was
weight.
the email you circulated around, Councillor Hay, isn't it?
Yeah, Val, will a briefing note be ready? Because
yes,
hang on, Val. If it's a briefing note for information and for us to comment internally together, that can be sent. That doesn't have to go on the agenda. That can be just sent around, excuse me, offline, as it were, as per lead member's instructions.
Right, fair enough.
Is that okay? Does that make sense? Val, are you happy with that?
Yeah, yes, it does. And I suppose it's a question for Councillor Hay as well, is that there were some kind of requests about action, about being taken forward, and whether they would need to be worked up more than the briefing paper and come as a more formal
That's what
paper.
I was thinking of, that they probably did need a bit more work on, and that we were going to get a short report.
We need to get another meeting just to make sure you would agree. I can get my team to put something together in more depth, but I think we probably need another meeting with the people that attended the meeting, and so that we know we can sort of get that agreement.
That would be handy.
Okay. Well, you could work with Anne to get that meeting up and running.
Yeah, we'll all organise that through Kate, great. Hopefully. She says hopefully. Sorry, I don't need to.
Poor Kate.
That's
Thank
okay.
you, Kate.
That's fine.
That's in advance.
You're very welcome.
Lorna, please.
You're very
Lorna.
welcome.
But you're very good at it.
Thank you, Chair. I wanted to raise the question of the Care Quality Commission report into the East of England Ambulance Trust, which found that staff and patients were being put at risk by poor leadership and a failure to tackle serious allegations such as sexual harassment, and the report from whistleblowers of sexual abuse, inappropriate behaviour and harassment. I do think we ought to be seeing the East of England Ambulance Trust, as these problems are apparently endemic and have been going on for a very long time, and I don't see anything in our forward plan that suggests we will be seeing them.
Okay, we can discuss that at the next Chair, Vice Chair, lead members, and we'll decide what we're going to do with that. Thank you. Yeah, and I think sometime in the future we definitely need to see them. Kate, you got your hand up.
Yeah, it was just to reiterate that, and to also just point out that in the past, when we have this was many years ago, we have scrutinised East. We did that as a range of health committees, scrutiny committees, because they're obviously a regional service. So I suspect very much that they're going to be called in by every scrutiny committee based on that report. But yes, I think that is a priority. So I was just pointing out the fact that they will be being pulled into scrutiny committees across the region.
Good. So they should. Thank you. Any other questions? No? Thank you. Thank you, Kate, as always. So item 12. Oh, no, we've done item 12. Hey. Oh, that's it. 19th of November, next meeting. Thanks all, everybody. Thank you very much indeed. Take care of yourselves. Thank you.